So I think we'll get started. I want to welcome everyone to our third annual patient investigator meeting at the ULF meeting. I'm Bert Kasiske. I'm president of cureCADASIL. I like to invert acknowledgments a little bit and give them up front, okay, because we've had a lot of input and help in putting this together. And in particular, our committee of three, which includes Jane Gunther, our scientific officer and past president, and has had really a lot to do with it. And our Fanny Elahi, who is our co-investigator on our CZI grant, also had much input. And then in particular, the community advisory group of patients, we really wanted to get an equal footing of patients in this meeting, and they also had a lot of suggestions and really reflect the program. So I think we'll get started, and I'm going to turn it over. Our first team here is going to be Coale, and who is a patient representative on our community advisory group, and Fanny Elahi, who is our co-investigator on the CZI grant from Mount Sinai, and they're going to kick it off with some discussion.
Should we just grab the chair?
Yeah, make yourself at home.
Thanks, Bert. Come here so you don't have the projector. Do we have people online?
Yes, I think there's about a dozen online. I should also comment that everything should go through microphones, or else the people who are listening online won't be able to hear. Okay, and we have extra.
Do we have two? So awesome.
There you go.
Thank you. Hi, everyone. It's great to see so many familiar faces, and I'm so glad that the faces are now familiar. So thanks so much, Key, for having this conversation. Key and I have had many conversations so that people understand what CADASIL is in reality, what it feels like to have a genetic diagnosis, and that life can be normal, or even in some respects maybe more meaningful sometimes. But this is a really special audience because you guys don't need an explanation about what CADASIL is. So I think we're going to take it in whatever direction you think best. But maybe let's start by having you introduce yourself.
Hi, everybody. Thanks, Fanny. I take every opportunity I can to speak with Fanny in front of anyone, so she knows that. So my name is Key, and I have CADASIL. I was diagnosed about 8 years ago. I just want to talk a little bit about that experience, and then how I met Fanny, and what being in her study has meant for me, and interrupt me if I'm skipping over anything. So I was diagnosed about 8 years ago. I live in the Bay Area, so I was diagnosed at UCSF. But I went through about 5 or 6 neurologists before I met Fanny. And I assume this experience is familiar with many of you, but it was a really terrible first year. And that process of trying to get the diagnosis and understand what the disease was, and sort of handle that process with my family, was really terrible. And I would love it if there's a way to sort of make that process easier and less painful for people. One of the first neurologists that I saw recommended that I take this meditation class, which in and of itself is a good idea, but it was a mindfulness meditation class through the hospital. And it was lovely, but I drove an hour each way to go to it, and I was surrounded by like terminal cancer patients. So my introduction was very grim. The message was very much, this is a terrible disease. We don't know anything about it, and things are going to get really bad pretty quickly, probably. So there was sort of processing that. I have 2 daughters who were young teenagers at the time. I was very worried that they would have the disease, and also that I didn't want them to find out that I had the disease. So I spent a lot of time and energy sort of trying to keep it secret from them, which I don't recommend. When I ended up telling them, it was it was a relief, and they weren't freaked out because they're so young. Even the concept of being in their 40s or 50s is completely foreign to them. So why would they worry about something that they have no concept of? So that was pretty rough. And then I met Dr. Elahi and learned about her study, and that experience of meeting her and eventually being involved in her study was completely transformative. The sort of combination of compassion and knowledge and dedication that she has and that her team has changed so much for me and so much for my family. So I just want to do anything I can to help her recruit more participants and support the work she's doing.
That's not a paid advertisement. So roughly how old were you when all this went down?
I was in my early 40s. And the reason that I sought out the diagnosis or had any idea I might have it is my father has CADASIL, and he's a very healthy man. But he had migraines when he was younger, and then he had a series of strokes in his late 50s in spite of not having any of the other associated risks. So he ended up seeing a neurologist who diagnosed him. And he actually didn't tell me about it initially, maybe for the same reasons I was worried to tell my daughters. But I had a conversation with him once, and I was talking about these migraines that I had, and he said, I had those as well. And then he ended up telling me about the disease.
How do you think the diagnosis has impacted your life choices and how you want to lead and live your life?
This sounds so Pollyanna-ish, but it's true. After that first year of being so miserable and frightened and sort of experiencing that existential crisis of having this really alienating disease that is no one understands that much about, or at the time it felt like no one understood or knew about. That first year was really hard, but since then, I'm fortunate enough to have a really lovely and supportive partner. So my husband and I, some things we decided to do is we decided to, I think Pedro called it YOLO last night, but not not wait to do things that we want to do. Really to figure out what are the things that we love in life and how can we maximize those whenever possible. We both started getting a lot of tattoos because why not?
That is a paid advertisement.
So there were signs from the outside for sure. But we love traveling to go see concerts, and so we do that whenever we can. I was able to stop working and to spend my time and energy taking care of our family and also just taking care of myself. I know that's not an option for a lot of people, but in my experience, reducing any kind of stress is the most important thing to do with this disease. Those first few years, I swear I manifested symptoms because I was so worried about them. So any reducing stress has been really important for me. And yeah, we just try to we both try to not sweat the small stuff because we've both had a lot of experience with big stuff, CADASIL, and then some other issues with our family, but that's been the most important.
And what do you do lifestyle-wise that helps you cope with the stress other than the sort of mindfulness?
Diet, sleep, exercise. I think exercise is probably the most important thing, and then it sort of waterfalls and helps with sleep and diet as well because you're just hungry for the right things when you exercise. I try to walk as much as possible. It feels like it's really good for you, and it sort of helps with the mind as well. I do take some supplements, but that's actually something that I wish there was a little bit more information about, because one thing I've noticed is that, I'm sure you all know, but the supplement industry is not very well regulated, and there's so much advertising, and on social media sites, when you start looking for something, then it just starts giving you all those things. And there's lots of claims of supplements that will help your brain. And I think I would love to know more about some of them and how effective they are. But I also worry that people are being it's a little bit predatory how they're marketed. So I worry about people wanting to take supplements that are helpful and ending up spending a lot of money without them being helpful.
100%. I've learned a lot from you, and you've been very open with, you've been really a partner in sort of pushing forward the research and doing it well. And one of the things that you told us is that when someone is diagnosed first, testing them is probably garbage because they're under shock. They're not in the right sort of state of mind. I'm just curious to hear from the audience how you guys feel about testing in general. When you participate in the studies, there's ours, there are other studies. How is that experience of getting tested? Terrible? Raise your hand. Decent? Okay. And then who was diagnosed and shortly thereafter tested? Not very many. You?
Yeah, what's interesting is I was tested this past December, but it was my brother who was being tested. My brother had some, he had fallen off but he had some things happen, and they couldn't figure out what was wrong. He had gotten tested for MS, and it wasn't that. And then I had a really peculiar thing that got me into the ER. They're like, we think you might have CADASIL, But I had great insurance, right? And it just, our circumstances opened up CADASIL in our family, but he was the one that was suffering the most, right? So, yeah, it's just, it was very awkward. I feel like we kind of had to bump into things. It was almost like we were falling down the stairs and trying to figure out where the heck we were at. And it took me having to be tested. Not that his doctors weren't great, but he wasn't insured, and so they were just, they were really struggling to figure out what was going on with him. And it took me having to be tested out of a freak little accident that opened everything up.
Got it. I should clarify, it's the cognitive testing that I meant. And so we've changed that, and it's been very meaningful because putting people through testing of their function when they are in a state of fear may not be really the best thing.
Yeah, I remember I had a meeting with a neurologist and sort of confirmed the diagnosis, and then right afterwards they wanted me to do the cognitive testing, and I was terrified in because CADASIL affects your mind, and your mind is what you use to do everything. It's sort of this cyclical thing of like, I also went through like that first year, I think I could have been diagnosed with clinical depression, but am I experiencing this depression because of CADASIL or because I just got diagnosed with CADASIL? But that testing, my sister had that same experience. They wanted to do the cognitive testing right after, and all of those questions when you're questioning your mind, counting backwards by 7 and, Ricky and his soccer ball in the backyard. It can feel really overwhelming. Now I'm trying to remember, so the next time I know it's the same questions, which, yeah.
Can you tell us about your pregnancies? You didn't actually know that you had a diagnosis, and how did it all go?
Yeah, so I had, the first migraine with an aura that I ever had was 2 days after my first daughter was born. And I assume some of you know what a weird experience that is, but everything just feels strange. And I was reading something at the time, and the words stopped making sense. They just became these indecipherable symbols. So they actually sent me to the ER because they thought, there's something that can happen after you give birth, a clot. And I waited around for hours, and they told me it was probably a pinched nerve and sent me home. And then I kept having these migraines at different hormonal junctions. So when I stopped breastfeeding, I had another one. And then with my second daughter, it was sort of a repeat of the same experience. So It wasn't until years later that I got the diagnosis. But in my experience, those hormonal triggers have been very, and I assume those also caused actual events in my brain that we can now see on the MRI. But I do think there's so much to be learned for women, especially with CADASIL, how and when it manifests and what those hormonal triggers can do.
Yeah. So I don't know about the events. We don't know if the migraines, but you had healthy full-term pregnancies. Kids were fine. You had migraines, but no strokes. It's just reassuring for anyone who wants to have kids, and many people in our study have had children, many of them. Obviously, I think pregnancy is risky, period, but women with CADASIL can have kids, and very healthy ones.
Getting out of bed is a risk, man.
Crossing, yes, exactly. Living, being born is the biggest risk. So tell us about how you mentioned having children when you received the diagnosis while being healthy. How did you deal with that, and how are you still dealing with it? Your kids are very young, but adults in some sense. So tell us about that.
Yeah, because I sent you all those panic texts a couple months ago, but one of my daughters, who she's brilliant, and she's my eldest, so sort of that typical type A eldest. And she has some minor struggles with mental health as well, just some self-induced because she's so busy and does so much. But recently she was having some bizarre symptoms, and I immediately thought it's CADASIL. And so I called Fanny, and she said it actually doesn't sound like CADASIL, and it was something else. But I encourage them. I encourage them to not do things that are bad for their brain. No cocaine, obviously. Take that off your list. No cigarettes. Just exercise. But I don't. I did for a while think they're going to have these shortened, terrible lives, and are they going to want to have children, and are they going to be able to find mates? Because that's a issue. My sister, who's 5 years younger than me, has the diagnosis as well, and she's currently single, and it's a real issue. Telling people and who to tell and what to expect from them. So yeah, I try not to worry about them, because I do think that I do think answers are coming soon and treatments are coming soon. And Fanny is so dedicated, and I know, even if I can't be helped with this disease, I'm pretty confident that my daughters will be able to, and my nieces and, grandchildren. So it was a big fear for me initially, and it's not as much anymore.
Thank you. Do we have more time? I want to open it up to everyone. Go ahead.
You talked about hormones changing things. I wondered how menopause will affect, like my daughter, when that time comes. Will that have an effect?
Well, not to share too much information, but I have gone through that within the past couple years, and I did, looking back, I didn't know what was going on, but looking back, I do feel like I had maybe one or two very small events, and I was also struggling with can and should I do hormone replacement therapy, which there's so much talk about it these days, and it seems like so many professionals are recommending it for people, and it's a really big question, is it a good idea? Could it help or could it hurt? It just seems like another issue that we don't know, and there hasn't been enough research on it yet, that relationship between hormones and CADASIL. But
100%. We don't know. So We think hormones could be helpful to the health of blood vessels, but it's probably person dependent, and there's always a risk with hormone replacement therapy. So until we know, I think it's a personal preference and how tolerable the symptoms of going through menopause actually are. But these are things that we really ought to get answers to, and I hope that we will in the years to come.
Can I add one more thing to that on that topic?
Yeah.
One thing that I also really appreciate about having Fanny in my corner and her research is that there are so many questions that come up with CADASIL related to health, like, you know, if you need surgery, how critical is the surgery, and should you avoid surgery because of CADASIL? There's other, you know, that everything from like, if you want to do yoga and you need to be on your head, is that bad for your brain? You know, if you traveling, you know, getting on an airplane. And Fanny has been so clear and honest with me in saying that, like, we don't know, you know, either we do know or we don't know. And if we don't know, her recommendation to me has always been like, think about this as a quality of life issue. Like, since we don't know, what is going to help you be happy and feel healthy and feel strong? And that's been very, I think about that often whenever I have to make some sort of decision like that.
I feel like I'm going through that first year. Oh, thanks. And so I wonder, are there recommendations, are people sharing, you know, that process of I mean, I'm clearly struggling to keep up with my high level work. And I do work in health access and equity, right? So it's right where my heart is at, both professionally and personally. I don't, you know, I don't know whether, like, or even how to move forward in figuring out if I can get SSDI, or like, I feel like I'm alone in trying to figure that part out, you know. And my brother, who's younger than me, himself is struggling. I just wonder, you know, are there places where folks share what, you know, what works, and even figuring out benefits? And I know everybody's experience is different. But I just wonder, how did you find your way? I don't want to have to fall down the stairs, and I don't mean physically, at least not yet, but in figuring this out, because I feel like I'm in the dark, you know, and it's really impacting, you know. I've got two of my beautiful children are sitting behind me, and one just got accepted into college, the other one's on his way to his third year, and it's just like, oh my God, this is when I need to work and I need to get them, you know. So I feel like I'm at a loss of how to even navigate helping myself and helping my family. So I wonder, you know, are folks sharing this? Is it documented? You know, I'd love to, you know, build community and kind of help me so I don't have to go through this, you know, challenging time at a loss of where to go and what to do, even to get myself I mean, emotionally, you know, at least I have my family and my mama and my spouse, et cetera, but like taking steps and knowing how to navigate this road is really painful, it's scary. I feel like I'm in the dark, you know, and and I've always been the eldest child, asking a gazillion questions and wanting to know everything, and I'm like, I feel so lost without knowing what are the steps that I'm supposed to follow.
Yeah, that's such a big question, and I empathize with you so much. I felt that way for so long as well, and I can't. There's so many really good questions you asked, and I can't answer all of them. And if someone can, in terms of resources, you know, CureCADASIL is a really important resource, and that might be your first place to look. There's Facebook support groups. I personally haven't found the Facebook support groups to be that helpful, because it's just sort of, you know, in that first year you go through this like sort of wanting to read the terrible stories but not wanting to read the terrible stories, and looking for inspiration, and all of the practical issues that you're facing feel so insurmountable. And I don't have anything helpful to say about that, but I do think that Bert, do you want to speak to this? Or Jane?
So
thank you, Keith, for sharing so much. And then June is also going to be sharing, living with CADASIL. And also here at the conference yesterday, they had the ULF ambassadors. So they're patients of different diseases, and there's an ambassador for each area of the US and Canada and also in Europe. And so that's another resource. But they won't be talking specifically about your disease, but they can provide a listening ear and maybe just hearing other people's, how other people went down that road. And they also they interact with each other, the ambassadors, so they all are learning about the resources that they can suggest to patients that come to them. So.
I'm happy to talk to you after.
And
Yeah.
this one went to
This is so incredibly common that we hear. We wanted to provide a peer support group. We just had so much that we wanted to do at the same time that we didn't have the bandwidth to do it properly. But I think this is much, much needed, and perhaps a grassroots effort that can begin and start with all the incredible people who are diagnosed, and some who are going through it, but others who have already gone through it. And think about what would be the best, and now online resources, right? What would be really the best resources? And we would be happy to contribute in whatever way, because people in the lab, Nikolaos is here, and there are others in the lab who are quite passionate, but they just didn't have the bandwidth to really take it off by themselves. But we will support this in whatever way is possible. Bert?
Can I finish up really quick? Just from personal experience and other people I've spoken to, the other thing is that it's the first year is terrifying. You feel lost and terrified and scared and alone. I will say from personal experience and the experience of other people in my family that have been diagnosed is that does fade a bit. It fades a bit because you wake up the next morning and you wake up the next morning and sort of life continues. And it's a really scary disease, but in my experience, it's much more gradual and slow, and you have time to sort of digest it and also realize that so many people are going through so many scary health things that you're not alone in that, and time is quite a balm in most ways. So, but just remember, that first year is so hard.
It's Nikolaos next.
Nikolaos.
Okay. All right. It's my pleasure to introduce Nikolaos Karvelas. He's really a brilliant postdoc in the lab, but a passionate researcher in CADASIL and anything vascular related. He obtained his medical degree in Greece and has been with us for the past 2 years, and is going to do his neurology residency here, and is here in the US to stay, and I think will dedicate his career to clinical trials and making treatments possible for CADASIL. Take it away.
Thank you, Fanny. It's my pleasure to be here because 2 years ago, this is where I first met with the CADASIL community, and it has really influenced my direction in this postdoc and in my future steps. So today I'm happy to give you a year in review with regards to the scientific studies that came out during 2024 and 2025. Before I begin, I have no disclosures of interest. So during the last 1.5 years, the interest in CADASIL has been strong. There have been about 120 studies published, and it was a difficult task to find out the ones that I think will have the most impact in future research and in clinical practice. I've picked some, and I've roughly divided them into 3 categories. The first one are basic studies that will impact how lab research will move on in the future. The second one is observational studies that tell us how CADASIL progresses over time and about what symptoms are important. And the third category is treatment, which we all know what it's about. So to begin with preclinical studies, there's a couple of laboratory studies that were very interesting. And for every study that we will be talking about, I will tell you why it matters to us, to the community. To begin with, the study on the left, it was performed at Anne Jutel's laboratory. You might know her from discovering the Notch3 mutation. And now she has progressed some steps further. She has shown that the mutated Notch3 protein aggregates with other mutated but also normal Notch3 proteins in the vasculature before you have loss of cells. So this might mean that it's a first step towards vascular degeneration and, of course, a possible treatment target in the future. You can see in the graph that Notch3 accumulation starts before you have the degeneration of vasculature. Another very interesting study was performed in mice and humans, but not necessarily CADASIL. It was in aging populations. And it showed that Notch3 loses its ability to function over time. And this results in vascular cell degeneration, in waste clearance issues. You can see the waste in Notch3 deficient aged brain. But what was important in this study is that they compared these findings with CADASIL, late-stage CADASIL, so that is brain tissue. And they found many similarities, such as waste accumulation, the degeneration of vascular cells, as well as difficulty of fibrosis to form. A next study that I found interesting is a novel assay developed by Dr. Wang's lab, who is here today. It's an assay that it uses two peptides that when they are in close contact, they emit a signal. And Dr. Wang put the Notch3 protein between these two peptides. And when you use the non-mutated version, the two proteins come in close contact and you have a signal. However, when the Notch3 protein is mutated and takes the wrong form, the misfolded version, you don't get this signal. And why this study is important is that it can be used in the future to identify the variants of unknown significance if they have pathogenic potential, and also when we get some treatments that may be able to return the mutated protein into its normally folded form. So I think that's interesting, and I'm interested to see how this will be used in the future. So going into clinical studies, we will begin with the observational ones. The most important study that came out this year was the CADASIL staging system. I believe Dr. Rutten, who is here today, was one of the main authors. This study created a novel clinical staging system, taking into account both clinical and imaging characteristics. And that's important because many people come to the clinic and they don't know how is their disease going to progress, what should they expect. They verified that this staging system worked across different cohorts, and they also found that it worked across different time frames, 2 years, 10 years, even 16 years. And as you can see on the graph on the right, across 2 years, there was some movement of some participants from some stages to later stages. So we can roughly know what's the possibility that a patient's disease will progress to another stage over 2 years. Another similar study from the group of Hugh Chabria discovered that the trajectories of many of the neuropsychological tests that you might have taken into the clinic. And I understand that this graph on the left that presents this test is difficult to interpret. However, bear with me. As you can see, some of the tests that you might know, like the Trails beat tests, seem to have a steep slope over the early years of CADASIL. So they can be used for both clinical progression tracking as well as an outcome in clinical studies in earlier CADASIL. And then on the right side, we have another very interesting study that was the first one to look into fatigue in CADASIL. It's one of the underappreciated symptoms which we found in the CADASIL survey, which we performed over the last 2 years. And they showed that it was mostly associated with depression and not cognitive decline. So this might tell us some information about how can we both target depression and fatigue? But we will probably also work more into this, and we will discuss more into this today. Then there's my own specialty, which is biomarkers. Biomarkers are either imaging or biofluid molecules that can be used to track disease and as outcomes in clinical studies. A study from our lab examined perivascular spaces, that is, areas around the vessels that are used to clear waste from the brain. And in CADASIL, it's very common in imaging to see that these are enlarged. That means that the waste is stagnated there. And we don't know what that means. So I found out that enlarged perivascular spaces were associated with worse clinical outcomes, worse white matter injury. So that means that they're clinically relevant. But I also looked into what proteins they're associated with. And I found that they're associated with proteins of inflammation. So that might mean that the vascular cells might be inflamed and you have these waste clearance issues. But of course, there is more to be done for this and to understand what's the significance. A very important study also from our lab used proteomics, that is measurements of 7,000 proteins in two CADASIL cohorts, one that was an early stage and one that was a later stage with strokes and cognitive decline. And we identified signature, that is a small set of proteins that divided, as you can see on the right, CADASIL people from people without CADASIL. And these signals were associated with fibrosis, metabolic dysfunction. So these signals can be used to derive either biomarkers or targets for therapeutic development. And finally, a smaller study in Korea used a known biomarker that is used in some other disorders. It's called neurofilament light. It's part of neurons, and it's released into the blood when neurons die. And it's used in multiple sclerosis, in Alzheimer's disease. And it also found that it was associated with worse cognitive function in CADASIL. So this might mean that it might be an interesting outcome in the future or a clinical tool that we could use. And the most important studies for the community, the treatment studies, they're slower than lab research, of course, because there's safety involved and all these steps. However, there were some developments. First, there were some studies examining an anti-migraine medication. It's case series. That means single people that use these medications. The medication is called a CGPR inhibitor, and it's a novel migraine treatment. And these case studies in 3 people showed that these people had less severity of migraines, meaning less migraines over a month, which were less severe than initially. And then there are 2 studies that examined the most used stroke treatment in acute settings. It's called thrombolysis, and it's used to bust the clots in the brain. And we didn't know if these were safe for people with CADASIL, because you might know that people with CADASIL also get hemorrhages. So the study on the left examined the patient files, and the one on the right examined 4 Japanese cohorts. And they found that people that received thrombolysis when they had a stroke were much more probable to be discharged from the hospital than the ones that didn't receive it. And the 12 people in the Japanese cohort study all had good outcomes. You can see there some of the lacunar strokes that these people got. And none of them developed hemorrhages in their brain. So that's important to know in treatment of these patients in the acute stroke setting. And finally, clinical trials. There were 2 protocols that were published this year. No results yet, unfortunately, but we expect some of these to release very soon. The one on the left examined adenomedulin. It's a vasodilator that helps blood flow to the brain. And it's a theory that in CADASIL there's less blood flowing to the brain, and that causes some of the deficits. And yeah, they're examining if it will improve blood flow. And there's another study on the right, once again, another vasodilator, but this time they use it to prevent stroke, because they showed in a limited sample of people that it might reduce the probability of getting a stroke. However, it wasn't a clinical trial. It was just an observational trial. So you need a control group, et cetera, et cetera. And yeah, I'm very looking forward into getting results from these studies because they will probably transform the way that we practice CADASIL treatment. So that was all from me. If you have questions about any of these studies, feel free. Yeah. To the clinical trials? Yes, this one.
Yeah, a question about clot busters and stroke treatment. So this seems like a big deal to me because one of the things I remember when I first got the diagnosis is there was a lot of information, you know, if and when you do have a stroke, you need to make sure that the ER knows this. So is this considered sort of conclusive that like stroke treatment, there are no special considerations if you are admitted to a hospital for a stroke, they can just sort of treat you like any stroke patient?
No, these were very preliminary reports. Of course, you need some trials that have a placebo. You need a larger number of patients, and you need to follow them at the same location. Because, for example, in this study, it was they used chart data. They didn't even have the patients in some pre-specified locations. But they are very encouraging results.
Yeah. It would be great. I mean, I long for the day when there's sort of clear information for CADASIL patients when they have events, what the correct treatment should, or the best treatment should be.
Can I jump in?
Of course.
Yeah. Yeah, we're going to have a session at the end, and so maybe we can discuss more. But I wanted to say that these are retrospective assessments, very, very different from prospective controlled trials. Placebo is not going to be an option for something like this. But I think what they do say is what we've sort of always advised everyone, that they should be thought about on an individual level, similar to everyone else walking in with a stroke, because CADASIL means blood vessel disease, and anyone who has a stroke has demonstrated that they have blood vessel disease. And so one of the risks of having blood vessel disease is ischemia, but also bleeding. So I think that what they need to do immediately is to know whether you have any old bleeds, symptomatic or non-symptomatic, which sort of plays into the pros and cons of a clot busting medication. And we certainly hope that in the future there will be safer and safer ways to do clot busting. In fact, Micheal Wang is a stroke doc. I'm a behavioral neurologist, but he's a stroke doc, and so he you could also comment.
So yeah, I think the jury is still out about whether it's safe or not, and these are preliminary studies, as Nikolaos and Fanny mentioned. I think it just means that we need to investigate it in more depth and more rigor. But there are certainly risks, as Fanny mentioned. If you have a history of bleeding and you get one of these medications, it puts you at extra risk for a major bleed that might get you into more trouble than you started with. So I think the jury's still out.
But it does mean that the ED shouldn't say, I'm not going to think about you, you have CADASIL, we won't even consider it. I think a lot of the emergency departments do that, and I think these studies just have it on hand, or a family member to have it on hand to say, look, like this is, you know, risk assessment like any other person.
Well said.
So I think
actually just one question from the virtual audience.
yes.
Are there any studies related to MRIs with contrast and any concerns about that and its safety?
I don't think there are, but
Go
ahead.
There are studies in small vessel disease with MRI with contrast, and we do know that some contrast can stay in the body, including the brain, but there are studies showing that it's not going to be toxic to the cells. Now, everything it's as time goes by, there's more and more level of evidence, but based on what has been done, I feel comfortable, and we're very, very conservative, but I feel comfortable that contrast is not a harmful thing. One disease to think about is multiple sclerosis, where there's a pretty pronounced rupture of the blood-brain barrier, maybe more so even than in CADASIL. And they get so many contrast enhanced imaging because it's one of the ways to determine whether you have active disease or not. And there really isn't any evidence that it's actually harmful to the disease process or that person. Michael, you wanted to say something? Okay.
So thanks. I think we're going to try to move on. You know, one of the big challenges, I think, for CADASIL is the heterogeneity of the clinical manifestations, okay? And particularly when we're thinking about clinical trials, both on the front end, trying to find a high-risk population that would be suitable for intervention in a clinical trial, but also within the clinical trial, finding people who we can identify with surrogate outcomes, for example, that could be endpoints in the trial. And so I think this is one of the big challenges facing us. And so we're having 2 speakers who are going to directly or indirectly hopefully address that. Our first one is Julie Rutten, who is no stranger to cureCADASIL, and we've worked with her a lot in the past. She's from Leiden, but she's currently in Suriname doing studies, and we're going to try to see if we can connect with her. Because she told me the other day she sent...
I'm online, Bert, if you can hear me.
Yes, we can hear you. Oh, good. Great. Fantastic. Take it away.
So far it works. Hi, good morning, everyone. I will also try to share my own screen. Oh, it's disabled. I don't know whether the host can enable me to share my screen. And otherwise, maybe it can be uploaded on your sites.
He's working on it.
Oh, yes, I will wait.
Does it work now? Someone asked that. Should try now?
Try again.
No, it's still host disabled. Still not working. Yes, now something is happening. Let me try. Can you see the presentation now on your screen?
Yes.
Yes? All right. So shall I start, Bert?
Yes, please.
Okay. So thank you again for allowing me to join this patient investigator meeting, at least online, and to share with you some of the research we do in the Netherlands on CADASIL. I have no disclosures for this presentation. So I work at the Leiden University Medical Center. It's a university hospital close to the sea in the Netherlands, and we are the Dutch expert center for CADASIL patients. So we have a multidisciplinary outpatient CADASIL clinic. We do all Notch3 DNA diagnostics in our lab, and we have a translational research group where we do, on the one hand, clinical studies in patients with a focus on genotype-phenotype correlations. We have a large biobank, and we work on disease modeling and therapy development. So we have been doing CADASIL research now since 1998 in the Netherlands, and I myself have been working on the disease already since 2011 now, so 15 years. Time goes very fast. So as Bert already mentioned, although I work in Leiden, I am now calling in from Suriname with usually okay internet, but I did send Bert a recorded version of this presentation just before the meeting. So in case the internet shuts down, then you can maybe use that one as a backup. But I'm keeping my fingers crossed that it will be okay throughout the presentation. So the cureCADASIL board already gave me a nice focus for the presentation today, as they asked me to discuss what the large difference in, on the one hand, pathogenic Notch3 variant frequency, and on the other hand, CADASIL disease severity means for future clinical trials. And I will break this down into several pieces, which is the content of this presentation. So I will discuss what do we call CADASIL causing Notch3 variants, our studies on CADASIL prevalence, and then looking at that from the clinical and the DNA perspective, and what have we learned from that, including the effect of Notch3 variant position on disease severity. And I will discuss this in the context of its relevance for future clinical trials. So to start with the definition of a CADASIL causing variant. So out of our 20,000 genes we have, there's only one single gene that is associated with CADASIL, and that's Notch3. There's no discussion about that, I would think. The variants that cause CADASIL are very stereotyped in both its type and also its location. So it's, with a few very rare exceptions, these are the variants that cause CADASIL are typically variants that lead to the gain or the loss of a cysteine residue in the Notch3 protein. And this change in cysteines is in a specific part of the Notch3 protein, namely the part that is outside of the cells, and to be more specific, in one of the 34 EGFR domains. Notch3 protein is important for healthy brain vessels, and if we zoom in on the brain vessels, let me try to get a pointer here. Let's see if this works. No, that doesn't work. Okay, well, in the middle part of the slide, you can see a cross-section of our brain vessel within the vessel wall, the vascular smooth muscle cells, and those are the cells that express Notch3 protein, of which a part is then inside the cell and another part is outside the cell. And so the CADASIL causing variants are in the part that is outside of the cell. So this is to zoom in a little bit more on the Notch3 protein. I've now flipped it horizontally and zoomed in especially on these 34 EGFR domains. So these are modular protein subunits, typically consisting of 30 to 40 amino acids, which per definition contain 6 cysteine amino acids. And these 6 cysteines form 3 disulfide bridges, and those are important for stabilization of the EGFR secondary structure. CADASIL causing variants can occur in almost any of these 34 EGFR domains. So I'm showing you here an example of a CADASIL causing variant in EGFR domain 3, leading to an additional cysteine, so 7 cysteines instead of the canonical number of 6 cysteines, and this is predicted to disrupt normal disulfide bridge formation. So this concept of cysteine altering Notch3 variants is nothing new. This is just to illustrate from one of the very first publications on Notch3 variants in CADASIL from the French group almost 30 years ago now, where they described the first CADASIL families and their Notch3 variants. And what you can see here is there are many different variants, but they all share the characteristic that either a cysteine, so a C, is changed to another amino acid, or a given amino acid has changed towards a cysteine. So these are the first variants described, but nowadays we know many, many different of these, what we call Notch3 cis variants, and novel variants are still being reported in the literature. So how does such a Notch3 cis variant then cause CADASIL? Well, the variant predisposes the protein to multimerize and to accumulate, what Nikolaos also alluded to already from the French study. So what you are seeing here in the second picture is a vessel of a CADASIL patient stained for Notch3, and everything which is brown here is accumulated Notch3. This is abnormal. And this protein accumulation leads to a whole cascade of pathological events that cause damage to the vessel wall, ultimately resulting in disturbed cerebral blood flow and brain parenchymal damage, which you can visualize on brain MRI in the form of white matter hyperintensities and legumes, and also results in the clinical symptoms of, for example, recurrent ischemic strokes and eventually vascular dementia. So to visualize it in a different way, again, here on the left-hand side, the healthy brain vessel, which Notch3 is expressed, and on the right-hand side, the CADASIL brain vessel, in which mutant Notch3 is expressed, is accumulating, and is recruiting other proteins into the aggregates, resulting in, for example, a thickened vessel wall and vessel wall fibrosis. So the question of CADASIL prevalence is something that has been intriguing or bothering us for quite some time now, as we've seen, and I think this is an experience which is shared by CADASIL clinicians and researchers throughout the world, that the number of patients we diagnose with CADASIL continues to increase. And not only the number of patients, but even complete novel families are still being ascertained in the clinic. So there's a lot of under and misdiagnosis. Around 2016, we tried to do a study looking at the estimated minimal prevalence of CADASIL in our country, and with the numbers we had at that time, we estimated a minimal prevalence of approximately 1 in 30,000 individuals. And that was similar as what has been found in other small prevalence studies. But we also thought this cannot be true because we are still identifying new families. We know many families of whom only one single patient has been diagnosed. That, of course, can never be the case in a dominantly inherited condition such as CADASIL. So we felt it must be a vast underestimation, but we could not really grasp it yet. So luckily, 2016 for geneticists was a super exciting time because that was the year that the first large open access genomic database was published. So this was at that time called the EXACT database, and it contains the genomic data, so all the DNA sequence of over 60,000 individuals, which you could just access online. Everyone could access it. So this allowed us to start looking at CADASIL prevalence not from the clinical perspective as we've done to date, but from the DNA perspective, namely first start looking at these typical CADASIL type NOTCH3 variants. How frequently do they occur in the general population? And what we found there was very surprising to us, namely that in that database, 1 in 300 individuals harbors a NOTCH3 cis variant, so a variant which we would found to be causative of CADASIL. So apparently, only 1%, because 1 in 300, it was 100-fold higher than what we would have expected based on the number of patients we were diagnosing at that time. So apparently only 1% of all individuals with a NOTCH3 cis mutation receives a CADASIL diagnosis. And then the question, of course, is what is going on to the other 99%? Are we missing all these CADASIL diagnoses? Or could it be that some individuals do have a NOTCH3 cis variant, but they never experience any clinical signs and symptoms? Or could it be that some individuals have a much milder and later onset phenotype, which might not be recognized by clinicians as being a genetic disorder, because clinicians usually suspect genetic disorder if it's relatively severe and early onset. Well, in short, what we found is that actually all these three explanations play a role, because our follow-up studies showed that NOTCH3 cis variants are in fact associated with a very broad disease severity spectrum, which we now refer to as the NOTCH3 associated small vessel disease spectrum, where CADASIL is actually at the very severe end of this spectrum, with relatively early onset and severe small vessel disease, such as strokes and vascular dementia starting in mid-adulthood. But patients with CADASIL are the exceptions of all individuals with a NOTCH3 cis variant, because much more frequently these variants cause a milder late onset small vessel disease. So for example, a patient experiencing TIAs and subtle cognitive decline beyond age 70. But we even identified individuals in this biobank. So this was a study in a UK biobank that we use data of. There were even individuals at age 70 with a completely normal brain MRI. So no signs and symptoms of CADASIL whatsoever at age 70. And then you might think, well, this is UK Biobank, maybe that's something very specific and it's completely different from the patients we see in the clinic. Well, it was not, because when we looked in our Dutch CADASIL registry, we also find these very mild cases. So these are brain MRIs of 7 individuals from our Dutch CADASIL registry, and all these individuals have a relative with a CADASIL diagnosis. And what I think you can appreciate from these brain MRIs is that they all have no or only little CADASIL-related abnormalities on the brain MRI, whereas all these individuals are 50 years of age or older. So also within diagnosed pedigrees, and sometimes these individuals have a first-degree relative with a clear CADASIL phenotype, these mild phenotypes can also occur. So clearly, one individual with a NOTCH3 variant is not the other. And this, of course, gives a lot of challenges also in therapy development. So we have a very high population frequency, 1 in 300 individuals minimally. But how are we then going to identify those individuals who are at high risk for developing CADASIL, for severe disease? Because those would be the patients that would first be eligible for potential treatments. Then there's this highly variable disease severity. So how are you then going to measure a therapeutic effect in a clinical trial if it's so diverse between individuals? So to tackle this latter problem, at least partly, and this is something that Nikolaos also already alluded to, is that we've now set up a staging system which allows us to uniformly describe the various disease severity stages that an individual with a NOTCH3 variant goes through. From stage 0, only having a NOTCH3 variant, way to the end stage for A with severe disability and in the end death. So this was a huge international effort which was coordinated by one of our postdocs, Guido Gravestein, in which many countries from around the world were involved, including the USA, and almost 2,000 patients were included in this study. So this is a quite easy to use staging system which describes the disease stages, with starting with only white matter hyperintensities in stage 1. These are then superimposed by lacunes in stage 2 and then result in more extensive brain damage with also clinical disability. So what's interesting is that an individual with a NOTCH3 variant, almost all individuals go through these stages sequentially. But the difference is some individuals already reach, for example, stage 3A when they are 45 years old, whereas others are only in stage 1A when they are, for example, age 70. And the question then, of course, is what determines this extreme disease variability? Well, what we found in the past years is that one of the key factors that determines whether an individual will develop CADASIL or a milder small vessel disease is the position of the NOTCH3 variant along the EGFR domains of the NOTCH3 protein. And we have now been able to stratify NOTCH3 variants into 3 risk categories for developing severe disease. So if the NOTCH3 variant is in one of these a bit reddish EGFR domains, which we call the high-risk EGFR domains, then the chance of developing a severe CADASIL phenotype is really high. So these are EGFR domains 1 to 6, 8, 11, and 26. Moderate risk individuals with a moderate risk variant, they can also develop a severe CADASIL phenotype, but the chance is just much lower, and on average, they have a later disease onset. And for the low-risk variants, those are the variants we typically see at very high frequencies in the general population, and they rarely cause CADASIL. They can, but those are really the exceptions. And what's interesting is that we found that these EGFR risk categories, as we call them, are also related to the load of NOTCH3 protein that is aggregating in the vessels. So an individual with a high-risk variant also on average has a higher NOTCH3 aggregation load in the vessels. So for some reason, NOTCH3 cis variants in the high-risk domain predisposed to more protein aggregation than do low-risk NOTCH3 variants. And why that's the case, we do not know at this moment, but it's something we are looking into. So these EGFR risk categories, we use them already in the clinic, in our patient's care for better disease prediction. So imagine if we see a patient aged 25 years, someone who comes from a known CADASIL family and as, for example, underwent predictive DNA testing because he had a child wish or he just wanted to know what can I expect for my future. Well, the first and foremost thing we address is see what is the exact NOTCH3 variant and in which EGFR domain is it located, because it makes a very big difference in terms of disease prediction. If this variant is in a low-risk EGFR domain, then the chance that this individual will have any clinical symptoms by age 50 is super, super low. We would expect if any symptoms would occur, it would be at a much later age. Whereas if it's, for example, a high-risk variant, then the story is really different. And then the disease is still variable, but patients should anticipate that it's likely that clinical symptoms will occur much earlier. So I'm now mainly talking about this genotype-phenotype correlation, but of course other disease modifiers also play a role and are important to take into account, such as the cardiovascular risk factors, which are important because those are things we can intervene in already. So hypertension should be controlled, and if possible, patients should quit smoking, and indeed, what was already mentioned, avoid hard drugs. Male sex, we know that males on average have a more severe phenotype than females, and there are still many unknown modifiers, because I also have to acknowledge, although NOTCH3 variant position is important, a large proportion of disease variability remains unexplained. So how is this relevant for future clinical trials? Well, I think that looking at the genotype can allow us to identify those patients at risk for early onset severe disease. So out of these many individuals with a NOTCH3 cis variant, based on the location of the variant, we can select those that would benefit most from a treatment and are at we have the highest unmet medical needs. Genotype is also important to take into account in clinical trial design. So imagine that you would do a trial and you have a treatment arm and a placebo arm. And by chance, all your high-risk patients are in your treatment arm and your moderate-risk patients are in your placebo arm. Then any therapeutic effect you would never be able to measure. It would be masked by the fact that these high-risk individuals tend to have a faster disease progression anyway. So when you design a trial, you have to think about this in advance. How are we going to take into account the genotype? And finally, it's also important to develop tailored biomarkers and readouts. And I will just, to almost finish my presentation, give you one example from our own center, where we did a study looking at the 2-year disease progression in individuals with high risk and with moderate risk NOTCH3 variants. And we looked at clinical outcomes, but also on brain MRI measures. And I'm just showing here 2 examples. Here under A on the left-hand side, it shows the mean skeletonized mean geophysicity, which is a marker for ultrastructural brain damage. And we found in a 2-year time frame that both high-risk and moderate-risk NOTCH3 individuals show a significant progression in MSMD, which makes this marker very promising for future clinical trials for both high and moderate risk NOTCH3 individuals. In this study, no low-risk variants were included. On the other hand, if you look on the right-hand side, normalized legume volume, we found that that only significantly increases in individuals with a high-risk variant, not in those with a moderate risk NOTCH3 variant. So this is something you have to think about in advance. Which kind of readout should I use, and what is the patient that I want to assess the therapeutic effect in? So to summarize, the definition of CADASIL is something that is still under debate, even at the last international CADASIL meeting, which was hosted in Paris at the end of last year. There was still discussion about this. What should we call CADASIL? Well, at this point, we would argue that CADASIL is what we would call the severe end of the NOTCH3 small vessel disease spectrum. And we hope that by defining these NOTCH3 small vessel disease stages, that the communication about individuals with NOTCH3 small vessel disease will be more clear and more transparent, and also that various disease cohorts can be more easily compared, because we know better what kind of stages are the patients in that are in a given study. The most important NOTCH3 determinant of disease severity is the NOTCH3 variant position, which gives great opportunities for identifying those patients at risk for early onset severe disease for clinical trials. And I think in clinical trial design, we should consider both the NOTCH3 variant position, but also the disease stage, because this is of course also different. Are you developing a therapy for someone who is still in stage 1, or someone who is in advanced stages? So these aspects are important for patient stratification and to develop tailored readouts and biomarkers. So with that, I would like to finish. I hope that the audio was okay throughout the presentation, and I would like to specifically thank here some members of our group of whom I've shared data, which are Saskia Lesnick-Oberstein, the PI of our group, Guido Gravestein, and our PhD students or former PhD students, Remco Hak and Minne Serfontaine. And thank you for your attention.
Thank you very much, Julie. We'll bring you back at the end there for our discussion period. Thank you very much. And next we'll have Micheal Wang, who is going to address the same topic from a different direction. Mike.
Great. Thank you, Bert. And I want to thank everybody for participating in this meeting. It's really great to see what the CADASIL community is all about, and the number of people who are invested in making progress in CADASIL, understanding CADASIL, and contributing to research and the goal of getting to therapies. Today I wanted to discuss a little bit about our philosophy about looking for therapies in CADASIL. So it's going to be kind of a high-level discussion of what we think we might do to get to a path for improving therapies. I'm from the University of Michigan, just 2 states down, and I've been working on CADASIL for about 20 years. I have a disclosure, which is that I'm a recipient of one of the cureCADASIL grants, and I'm very appreciative for that. So here's kind of the roadmap of what we want to talk about today. As I mentioned, we want to talk about, in general, what strategies exist for going after diseases like CADASIL. And then I want to talk about some ideas that we have about mutation-specific therapies. So what are some of the strategies to overcoming CADASIL? To really talk about strategies, let's talk about, in general, what diseases, how diseases progress. We know in CADASIL that there are several stages of disease progression. So it all starts out with Notch3 mutations. And what I've done up here is illustrated normal Notch3 with a pink square. And we all know that CADASIL is caused by genetic mutations in Notch3, and these genetic mutations cause abnormalities in Notch3, which is depicted by this angry-looking red trapezoid, and that represents misformed Notch3. So when we have a mutation in Notch3, the protein changes, and now it's a different shape. And what happens with a different shaped protein is that many times it can break up into proteins that don't exist in the vessels normally, or it can attract other proteins, which are depicted in the blue shapes. So the blue shapes are other proteins that latch on to abnormally shaped Notch3 proteins. And what happens when you have these accumulations of Notch3, abnormalities in Notch3, and proteins that don't normally associate with Notch3, these blue shapes, is that these protein aggregates can cause mischief in blood vessels, which is depicted over on the right side. And when you have problems with the blood vessels, then you can get problems within the brain. So these include toxicity to cells in the vessels, abnormal vessels, and disease symptoms, all the way on the right. So you can see that there's an ordered progression in problems, starting with the Notch3 mutation, ending with what people experience, which is strokes and cognitive impairment and mental health concerns. So you can imagine that you can intervene in any of these stages. So what I call here early stage therapy is the idea that you can intervene in the process where Notch3 changes shape from this nice pink square into this angry red trapezoid. Alternatively, you could suggest going after abnormal Notch3 and preventing this red abnormal protein from associating with the blue shape there. And then finally, you could go into a late stage therapy, which is to try to block the functions of these protein aggregates to prevent things from occurring in the brain. And what I'd like to suggest to you is that early stage therapy might be a more effective way at going after the disease. And that kind of makes sense, right? If you have a multiple stage progression of disease, wouldn't it be great to intervene in the very, very first stages? This has the advantage of being more efficacious, potentially. If you intervene really, really early, you can prevent the mid-stage and the late-stage processes in the cells and in the brain. It's a rather simple concept because you're going after one protein, Notch3, rather than a bunch of other different proteins or a bunch of different forms. It's also attractive because we know what to go after. We know we have to go after Notch3. We're not so sure what all those blue squares and blue shapes are in this disease pathway. And also there's precedent for doing this. In other diseases, when you go after the early proteins, the early stages of diseases, you're more likely to succeed at overcoming the disease process. So in general, we believe that going after this process, this early process where Notch is converted into an abnormal Notch3 protein might be one way to go in looking for therapies. But there are some challenges, and the theme of this session and what Julie has talked about in the last talk is that there is quite a bit of heterogeneity. So there's a lot of diversity in the Notch3 mutations. It's not just one Notch mutation that causes the disease. It's a whole cluster of them. And this is illustrated in Jutel's early work from 1997, which shows just a snapshot of the early mutations that cause Notch3. Now there are hundreds of mutations that are known. So the problem with heterogeneity is that when you have different mutation, it's predicted that you'll have different shapes of Notch3. So instead of just one angry red protein, you potentially have multiple angry red proteins that are different shapes. So how do we address that? If we try to figure out how to prevent one of those shapes, that might help one person or one family, but all the other patients with CADASIL may not be candidates for this type of therapy. So there are a couple of strategies for overcoming that and still looking at early stages in Notch. One would be to try to find broadly acting drugs. So are there chemicals around drugs that can be used to bind to Notch3 in its abnormal state that might work for lots of different Notch3 mutations? I think another possibility would be personalized medicine. So is it possible to develop a drug against one mutation and a separate drug against another mutation and a third drug against a third mutation, and then tailor your treatment towards a specific mutation? Well, that sounds really difficult because there are hundreds of different mutations, but there is some precedent for this. If you think about what cystic fibrosis patients are treated with right now, it's not just one drug, it's a series of drugs. And when a patient has cystic fibrosis, you sequence the CFTR gene, you find out which mutation they have, and based on that mutation, you treat them with one of 4 or 5 different drugs. So this is possible for CADASIL. It is a challenging ask, but it's possible that one drug for CADASIL might work for a subset of Notch3 mutations. And if we can find those, it's kind of an intermediate between broadly acting drugs and personalized approaches for the disease. There are other approaches which have been proposed. One could develop monoclonal antibodies against Notch3, which react with mutated Notch3, these angry red proteins, and are broadly able to suck that abnormal protein out of blood vessels. And Saskia Oberstein and Julie Rutten have also published on attacking CADASIL at the RNA level. So you could potentially cause exon skipping and suppress mutant forms of Notch3 by engineering ways to get the cell to not make mutant protein, or you can block gene expression. So those are theoretical ways. I just wanted to show you some of the approaches that we're taking in our lab, just to give you a little bit of a sample of what might be coming up in the future. So Nikolaos, thank you for introducing our paper. I won't need to discuss it much, but we have developed a genetic screen that differentiates between mutant and CADASIL linked proteins, and you can see here on the red that we can differentiate a mutant protein from a wild type protein by a low level of activity in this genetic system. So basically we've built a chemical sensor that can read out Notch3 problems, and we can use that in the lab to see whether a Notch3, when mutated, has a problem. So what does that mean in terms of drug development? Well, what we've done recently is we've taken chemicals that we predict might react with mutated Notch3, and we've used them in this laboratory setting to see whether we can convert a mutant Notch3 into a more normal looking protein. And if we're successful in converting a mutant Notch3 protein into a more normal looking protein, the level of activity in this assay goes up. And we've succeeded in using off-the-shelf laboratory chemicals that are predicted to react with Notch3 in increasing levels of CADASIL-linked protein, which are the red proteins. We've succeeded in normalizing the activity of these proteins. So we've raised the bar on these red proteins so that they look more like normal wild-type proteins. And that's interesting to us because that indicates that there are chemicals out there that can potentially reverse the problems that Notch3 mutations cause. And it also indicates that some of these chemicals can broadly act against many different mutants. So these chemicals are not drugs, but we're hoping to find drugs that might have the same properties. So that leads us to what we can do next. So in the research world, we are planning, with the help of the cureCADASIL grant, to screen drug libraries using this assay to try to find chemicals that are actually used as drugs that might behave in this way. They might be able to reverse these early stage processes where Notch is converted into an abnormal shape protein. And we may be able to propose those chemicals as potential investigational drugs. To do that, I think we need to do what many speakers have mentioned already, and that is to develop biomarkers so that we can effectively do clinical trials. We don't have the luxury of doing 10, 20-year clinical trials and looking at outcomes. We need biomarkers, preferably things that we can measure in the blood to help us know whether we're on track with any of these chemicals that might be used in a clinical study. And what can we do as a community, both researchers, physicians, and people affected by CADASIL? I think what you're doing right now is getting involved in CADASIL and finding out what research is out there. We need help engaging as many people as possible in clinical characterization studies which allow us to develop biomarkers that can be used in the future for research studies. And then we also need patients, families to continue to engage with other stakeholders in the research world. We appreciate any support you can give us, engaging with NIH, engaging with the pharmaceutical world, to let them know how you're affected by CADASIL and how important this disease is, because that helps us as a community strive to achieve what we all want to achieve. So I'll just summarize really quickly what we've just talked about over the last few minutes. CADASIL is a very heterogeneous disease, which can be a problem when you're designing strategies for early stage treatment. But I think that we can overcome it. I think it's likely that we can overcome it. And I believe that early stage treatments are feasible. It's not a promise, but I think that this route of investigation might yield some clues as to where we can go in the future. And we are making progress in tackling Notch 3 alterations in CADASIL. We are understanding this process in detail, more at the molecular level, as time goes by. So I also want to introduce you to our CADASIL research team in Michigan. These are 2 snapshots in time. It's a great team. We have undergraduate students, graduate students, and some very talented staff who have been in my lab. I just wanted to highlight Sue Lee, Xiaojia Zhang, and May Pearl, who have been in my lab for quite some time. I think collectively between the 4 of us, we have about 70 years of CADASIL research under our belts. So we're committed. We've taken the long view, and I hope it pays off. I also wanted to acknowledge the really fruitful collaboration we've had with Fanny's lab in New York. It's really been fun working with you, Fanny, and I think our collaboration brings a lot of energy to what we're striving for. Of course, we've been funded well in the past, and I just wanted to acknowledge NIH, the VA, the university, cureCADASIL, of course. CADASIL Together We Have Hope, and Fanny's CZI grant has been very helpful. And of course, I want to thank all the CADASIL patients I've met and their family members. You guys provide great inspiration for what we do. Okay, so I think just want to leave some time for discussion.
Right, we'll bring you back. We're a little behind, but we'll bring you back at the end and can have more questions. And so Fanny and June, you want to?
Well, first of all, that's amazing, Micheal. The work that you do is so amazing, and you've created a platform for drug screening that's incredibly powerful, and it's been so fun to work with you.
These patient history studies are incredibly valuable for paving the way for clinical trials. These are natural history studies, which means there is no treatment involved, and the participants are seen by some of the most experienced CADASIL clinical researchers and physicians in the US, and Fanny is one of them. And the goal of these studies is to track changes over time, identify patterns in progression of the disease, and help identify meaningful outcomes for future clinical trials, which you've heard those outcomes called biomarkers. We are also excited to share that cureCADASIL is launching a new patient history study through our new patient registry. It's going to be much more powerful than our previous registry. And this is another step forward in building a strong foundation for getting into clinical trials. So whether you are already participating in a study or just curious, I hope that this session gives you a clearer understanding of how your involvement in patient history studies helps move the science forward. Our first speaker is Karen Orjuela. I'm not going to say your name correct. Karen, do you want to come up and introduce yourself? It's so nice to meet you in person.
Thank you, of course. You can call me Dr. O, if it's easier. I have to leave my phone on. Is that okay? Just I'm on call, so. But my name is Karen Orjuela. I work at the University of Chicago, and I'm a vascular neurologist, and I'm part of the NIH Consortium in CADASIL. So previously I was in Colorado, where I had the experience to work closely with the CADASIL patient population in that area, in kind of like the middle of the country. So I don't know if my slides are ready. Thank you. Thank you. I have no disclosures for this talk as well. Okay, so thank you. So I'm speaking on behalf of the investigators and the research partners at the NIH. So we can keep going. So I'm gonna give. Oh, here. Oh, perfect. Thank you. Okay, perfect. So I'm gonna just do a quick overview of the study, the progress. Of course, we have not sort of like the ability or power to still kind of like share all the data. So, but I'm gonna tell you where we are right now. So the study so far is an NIH-funded 5 years observational study, meaning that we don't provide medications or treatment, etc. And we basically are tracking longitudinal changes in NOSH3 carriers and non-carriers at 12 US research sites. So the sample size so far is 500 participants with or at risk of CADASIL. And basically the schedule of the observational study is 3 in-person visits at 12 months intervals with some, of course, remote or telehealth options that are available. So we take some blood samples, perform MRI scans, cognitive testing, neurological examination, a little bit more in detail than the others, interviews about mental and physical health, and a companion interview either in person or remote as well. So the study goals are characterize the initial presentation and course of clinical neuroimaging and biofluid markers of CADASIL, and determine how these stages of disease severely should be assessed. We aim to clarify genetic, health, and lifestyle factors that impact clinically the outcomes in CADASIL, and characterize also what are the variations, the risk increasing behaviors, medical conditions, and Alzheimer's disease markers that could influence the onset of CADASIL or the presentation. And of course, an overarching goal is developing a model for CADASIL that is also broadly applicable to vascular cognitive disease, like more broadly, which is very prevalent in our world, and dementia. So far the study, as far as enrollment, so we have like 561 visits. It could be all participants, and the visit 2 is we're kind of like aiming to increase those numbers, of course, to match the longitudinal goal of the study. And visit 3, so the 18 months will be completed, like the second sort of like cycle in July this year, so very soon. So here's the map. A little bit of the sites are part of the study. So the West Coast, kind of like West still, Utah, Colorado, and Midwest and East Coast too. So we have a little bit of more kind of like geographic diversity in our study. Yes, you want to take a picture, please go ahead. Great. So there are optional research activities with the consortium as well, and there are sort of like partners within the investigators as well. So those are optional research activities if you are interested. So basically to explore with more imaging with 4D flow MRI, how does the brain blood flow related to sort of vascular risk factors, and there are other sort of like goals of those studies as well. We have also another sort of like imaging related. So how does your brain, do your brain's blood vessels respond to changes in your breathing pattern? And those are kind of like also studies that are coming from University of Madison as well. There are also, and Dr. Paulsen, who is the main principal investigator, is interested in understanding how, if we examine the blood vessels in the eye, can we better understand the health of those vessels in the brain as well? So those are kind of like observational, non-interventional research opportunities as well. And there are like future submissions in grants with the consortium that are related to the ethics, for example, or returning individual results to research participants as well. So please, if of course you would like to invite you to join the CADASIL registry. By enrolling to a registry, your name of course will be added to this. So if you want to scan that, feel free to do it as well. Or the slides I think that are available also for your use. So there are different community resources that perhaps you are aware of their existence as well, that the team wanted just to highlight as well. And there's going to be an upcoming webinar with the main principal investigator, I think in a few weeks. So that would be great if you can also hear from her. Monday? Okay, perfect, yeah. On Monday, so she might be able to tell a little bit more specific details, but I think that so far we're kind of like trying to analyze all the data so far, but of course longitudinal studies require that we complete the follow-up. So if you are part of the study or know who is, it's important just to keep track of that and just make sure that we have time passing so we can actually collect the data and see if there are any changes as well. So it is part of the team, not all the team, but part of the team as well. And thank you so much.
Thank you so much. Our next speaker is Elisa Ferrante, and this will be done remotely. I hope.
Hi, everyone. Let me try to share my screen and we'll go from there. Okay. Can you guys see my slides? Yes? I can't see myself anymore, so I need someone to tell me.
Yes, we can see him.
Okay,
Perfect.
fantastic. So, thank you guys for having me. Unfortunately, I couldn't come in person this year, and I'm presenting virtually, but I'm still very happy to be here. I am the principal investigator of a CADASIL 2 study at National Institutes of Health, or NIH, which you've heard mentioned a few times. And we have one of the many studies that you'll hear about today. And let me preface this with, I'm very glad that there are other studies that people are also participating in, because the more information, the better. And we all talk to each other. I know Fanny Elahi, I know Jane Paulson. So it's really exciting to see everyone come together for this. I don't have any disclosures, get that out of the way. And so to give you the background, we've had now 2 studies. That's why we call the current study CADASIL 2, very original. It is a natural history study, and we have one that is completed and one that is ongoing. So our natural history study started in 2016, and we had 20 patients, so it was a pilot study, very small. We had people come back every year for visits, and we were very interested in understanding the molecular disease mechanism and figuring out the clinical correlation. And as many other people have mentioned, this turned out to be a difficult task to achieve because the disease is so heterogeneous that we were seeing a gamut of different clinical presentations, even in siblings that carry the exact same mutation. And so from that study, which was pretty short, it concluded in 2022, slowed down a little bit for the COVID pandemic. We developed another study, and this one is much larger. Our goal is to accrue 100 patients with confirmed NOTCH3 variants, as well as a counterpart of about 40 healthy volunteers. And our patients will tell you we often try to recruit their spouses that visit with them for the healthy volunteers because it matches the age demographic information, which is really nice. And what we understood from the first study is we needed to look long term. And so now we bring patients in every 3 years, and we're hoping to achieve a goal of about 9 years. So on new patients that come for visit 1 under CADASIL 2, we'll have 9 years of data. And then from CADASIL 1, we actually invited a lot of those patients to come back. So some of them have started coming for their visit 2 here at NIH this year. And on them, we already have about 8 years of longitudinal data, which is great. So we're very interested in understanding the progression of CADASIL, particularly as it relates to those different genotypes that Dr. Rutten talked about, and continuing to examine the pathogenesis. And we do want to understand the variability of the genotype clinical phenotype, particularly in the context of people having the same variants. What else is causing the differences in their clinical presentation? Our evaluations take 3 to 5 days. We do your typical clinical evaluations, clinical labs, collect biospecimens, blood and skin biopsy. And then we have a very large team of investigators across all of NIH that are helping with the neurology, the eye exam, the genetics. We do a brain MRI, both 3T and 7T, vascular studies that are non-invasive, and cognitive testing, like most of our studies. And so to give you a little bit of what we've already determined from CADASIL 1, because I know the time is short, is we use the brain MRIs. And for us, it's very critical to make sure that we have the brain MRIs on the same type of equipment every time a patient comes, because it allows us to identify changes over time and to actually quantify those changes. So with a collaboration at the Stroke Institute, we were able to develop machine learning methods that have allowed us to look over time at how these changes in white matter in the brain are progressing. And so it's a little bit difficult to interpret the data, but when we compare from the first visit to year 1, you can see we have a baseline measurement that is already changing a little bit. And then you compare baseline to year 2, you see a little more changes. They are small changes because there's only a 1-year interval, which is why we're now looking at 3-year intervals, and that data will be analyzed hopefully soon. So maybe I can share it next time. And then the other thing that we think is very interesting and could potentially be a clinical biomarker down the line is we measure something called a pulse wave velocity. So we use a tool that is non-invasive that we can put at different places of the body with probes, and we can measure how the pulse travels across the body from the neck all the way to the legs, for example. And what we have noticed in CADASIL is that when you compare patients with CADASIL to controls or healthy volunteers, as you would expect with healthy volunteers, as people age, their blood vessels become stiffer. But when we compare the same age groups or same age range to CADASIL patients, this line remains relatively flat, which tells us that their blood vessels are a little more elastic. So they're a little more flexible than patients with your normal aging vascular stiffening. And the caveat of this is, of course, I'm at National Heart, Lung, and Blood Institute, and we're always interested in blood vessels. And the other takeaway from this is, while yes, this is a small vessel disease of the brain, Notch3 is expressed throughout the entire vasculature, and there are non-invasive ways that we can see changes in the vasculature in other areas of the body. Now in CADASIL 2, for example, we're doing a test called nail fold capillaroscopy that allows us to see the capillaries in the nail bed. And we're seeing differences there too between healthy controls and our CADASIL patients. So there are other ways other than the brain MRI where we can identify changes and potentially use them for outcomes when we get to that treatment study, which hopefully will be coming. So the conclusion from our CADASIL 1 study was that we did see very slow progression over the 3-year study. We saw typical white matter changes in every single patient, regardless of the Notch3 variant that they possessed. Of course, variable genetics, that was similar to variable clinical symptom presentation. On the neuropsychometric, the cognitive testing, we see that balance of verbal visual learning and the psychomotor domains were the most affected over time. And the data is currently in the analysis. And I know I said this last year as well. It turns out because everything is so heterogeneous, it's a little bit difficult to get this data out there, but I'm really hoping to share that publication with everyone soon. And so our second CADASIL study aims to further help us understand the disease mechanisms, because the NOSH3 variants are so variable, and the disease presentation is so variable, we still don't know what the disease mechanism is. And that can be a key that allows us to identify possible treatments eventually. And what I have loved about NIH since I started working there in 2016 is the NIH is very good at repurposing drugs and bringing people in to test these things. So fingers crossed that that is in the future. And beating the nail on the head, biomarkers are absolutely critical. So like many other people, we are also a translational medicine research lab. And we're working pretty hard with our patient samples to be able to try and identify biomarkers circulating in the blood, for example, that can help understand the disease, diagnose the disease, and then serve as outcome measures for treatments. We also do develop stem cells from the skin biopsies we get from the patients. And we have built disease models that are stem cell based. For example, we do vascular organoids and are developing a brain vascular organoid that will allow us to use this platform to hopefully screen different medications to help us identify the treatments, but then also help us understand if this is something that is helpful in those disease model systems. And then, of course, like others have said, study participants are absolutely critical for us to be able to do this research, as well as the collaborations that we have between all of us. This is really key. And just sharing our study flyer, you can scan the QR code and you can do a screening phone call with us. You can also email me at any time with questions, or if you'd like to be a participant in the study. We're always happy to have you. We're also very happy if people are participating in other studies. That is not an exclusion item for us. We're just really glad that there is this partnership between all of us, including cureCADASIL, as well as our patients, and we're very thankful for that.
Thank you very much for that great talk. And this is the longest patient history study in the U.S. Our next speaker is Fanny Elahi. Sure.
No disclosures. But I have to say that I wish that we did have disclosures, because it would mean that we've developed some drugs. And that's way better for all of us. So sadly, no disclosures, but I really hope yet. And that was it. Where are my slides? All right, I can start by talking about it. My only disclosure is that life has thrown a few curveballs my way, and so I didn't have time to actually put together my slides. And this is how amazing my team actually is. So it's their slides, which means that if it's good, it's them, and if you think it's not, it's also them. And I'll start by telling you about the design of the study. So our goal is squarely focused on, no, this is the next one. But our goal is really drug development. I would say drug discovery, because there are multiple components to that. And Micheal had beautiful slides and very, very clearly explained what that means. It means repurposing some drugs. It means going for the different stages of the biology. And ultimately, what we hope is to cure CADASIL. And that may mean CRISPRing the gene, but we're really, really far from that. I mean, so to speak. That's probably the highest bar, right? And I hope that before the world is ready for that, because we don't want to wait that long, we're going to have other treatments that are going to slow down progression and allow ultimately for cures for everyone. This is it. Awesome. So our study is about precision, and we think that we can, with the tools such as Micheal's tool and some of the in vitro iPSC-derived modeling that we're doing, alongside the biomarker work that everyone is doing, we can try to understand the biology and its connection to the clinical symptomatology better and be able to have multiple different therapeutic avenues. So that's really core to the study, and I'm a very impatient person myself. So I really empathize with everyone coming to the study, and so we've tried to make it as minimalistic as possible, which means that we've cut out anything that we don't think is absolutely necessary. What is absolutely necessary is blood, because without molecular biomarkers, I don't think we're gonna be able to track even therapeutic efficacy, especially in the time period that we all want to know. We don't want to wait years before we know you have less strokes or no strokes. We want to have sort of go, no goes, and we really need those molecular biomarkers. Those are the reason why we have an anti-amyloid treatment for Alzheimer's disease. So molecular biomarkers are key. So blood, you don't get away without a stick in the study. So we do collect blood. And then brain imaging is really optional. We can use clinical scans for that. And then some sort of testing. We try to keep it as light as possible, so it's not hours of testing, but we need some assessment of testing. And we know that the direct cognitive testing is also not always 100% accurate, but it gives us sort of a ballpark. So we have two options. Since blood is the most important component and that the clinical testing doesn't need to be extensive, we have opened the study to remote participation since a long time ago. Actually, COVID was the inspiration for that. We realized that the world goes around and we get things done despite the extensive sort of in-person testing. So the remote cohort means you connect with us by Zoom, and we send a mobile phlebotomy to your home. I apologize for anyone who had a bad experience. It's a company that we use. So sometimes they make mistakes, and sometimes they're not the best at drawing blood, but they're better than us, I think, most parts, for drawing blood. This is a little bit small, but you can see that the required procedures are blood, some sort of cognitive testing, some questionnaires, and we want to make those questionnaires better, actually. So one of the questionnaires that we're going to be circulating, maybe by electronically, we don't need to bring you in for that, is fatigue. We're still working on which we think is more reliable, and we may contact you to get your thoughts on whether you think this would be capturing fatigue, if you experience fatigue. And then the optional studies are actigraphy. So many of you have actually participated in this. It's not just sleep, but it's also movement. I think the future of phenotyping and understanding disease is going to be a lot less invasive, a lot less confrontational. And we're very actively thinking about better, more quantitative, less sort of in-your-face, burdensome ways of actually doing that. And actigraphy is really, really attractive. It's been shown to work for a lot of other disorders. You can predict Parkinson's or Parkinsonism years before someone actually develops frank symptoms. So we're really interested in taking that forward. It's really cold in this room. Okay. All right. And then so there you go. So I'm not the only one whose like teeth are about to, okay. So study demographics, the team pulled some data, and this is the age distribution, which is awesome. You can see a really nice distribution. We have older individuals and some healthy older individuals. So This is the distribution in June. As always, women are participating more. That's no surprise to anyone. This is by level of education. We have diversity there. And then this is basically so we don't require you to have a Notch3 mutation. We actually really want to understand where Notch3 mutations stand. And we think that there's a lot more to be learned if we allow people who suspect they may have CADASIL or just have a syndrome, a clinical presentation that looks like it, to be able to participate. So this is showing you the distribution of the study. This is showing you the cognition, which is, for the most part, excellent. If you look at a neurodegenerative disease cohort, this is not what the cognitive scores look like. These are global cognitive scores, MoCA. So most people have really high cognition. This is the remote MoCA. I kind of blame my team. I'm investigating that. I want to see whether we're good at administrating remote MoCA, but it also may be that when people are more symptomatic, they can't come into the study. So it's possible that sicker individuals are actually connecting remotely, which I love. I think there's a part of the disease that sort of we don't understand anymore because we can't bring people in. And that was also the purpose of allowing people to participate wherever they are. This is the comorbidities, and you can see that high cholesterol is actually really, really, really common. So I think we need to really understand that and to see whether it matters or not. And I think to have better ways to quantify. This is by report, but I think we would love to connect charts, clinical charts, and pull this, again, sort of decrease the burden and increase the accuracy. Next steps is people. Next steps, I think, is harmonizing maybe across studies. For us, our own next steps and what's in the works, I think you get a newsletter through cureCADASIL that tells you, but I'll just tell you that what we've discovered, and there's now a dedicated team investigating this, is that there are signals from the immune system that are arising. So we think that that may be a part of the biology that had been overlooked because of the focus on blood vessels. But we know that circulating immune cells are constantly in contact with blood vessels. And we actually know that Notch3 is expressed in a subset of white blood cells. So the blood that we're collecting from you is going to a deep analysis of the immune system. That's one area that's very new. And then we're continuing to build the in vitro systems. We now have several systems that are working really robustly. And we're building, quote unquote, more complicated systems where we're looking at the interaction of multiple different cells together. Forming mini brains is a really big word, mini soup of cells. But it's been very informative. And then really impactful collaborations, such as the one that we have with Micheal, where we're basically bringing in all the tools in the toolkit together and seeing whether we can get more robust therapeutic indications and answers. And this is the team behind the magic. So we have a clinical research team, as you know, because we have a clinical study. We have bench scientists who use the material provided to understand the biology. And then we have computational scientists. We, like many others, are using more advanced analytical methods to sort of make sense of the very rich multimodal data. And then we hope that all of these so I haven't even had time to make some of the photos clean because there's a turnover and there are new people joining. But I think what has been really, really heartwarming is, and Stephen Fitzsimons, his name is there, I think one of the heartwarming things is that people are going on to continue to care and work on CADASIL. And this, I hope, will have a much long-lasting and bigger impact than the work that just comes out of the lab. And I can't thank you guys enough for partnering with us and for cureCADASIL. I think we really got lucky with that initial grant that I think we stood no chance of getting together, but we did. And it's been really quite the journey. So I hope that all this work collectively in our study, in the studies that you heard, are finally going to reach the point of bringing some therapies for this community. Thank you.
Thank you, Fanny. And a little bit about the grant that she had mentioned is a patient-partnered research grant. There were 5 that are awarded by the Chan Zuckerberg Initiative, and there are just under 300 applicants worldwide. So, oh, maybe even better. Fanny thought maybe it was 500 applicants, but it was a competitive a grant, and it was a $2 million grant over 4 years. We're in year 3, so. And our next speaker is Bert Kasiske from cureCADASIL.
Okay. So I want to tell you about a new registry. And you might ask, well, why do we want a new registry? And we're just to the stage actually where we're testing the survey, and it's going to be up and going pretty soon, and it's replacing the registry that we currently have, that cureCADASIL currently has. And our current registry is the CADASIL Family Registry. This registry was started back in 2016. It was really done. It was done by a genetic testing company, Invita. And it was really a one-size-fit-all registry. That is, they offered a registry for any rare disease. So there was nothing specific about it being directed. None of the questions were specific, for CADASIL per se. And another problem was that we didn't own the data. So, to do anything, you have to go back through the company. And then finally, the icing on the cake problem was that Invita went bankrupt and was bought by LabCorp, and is still the status of where we can get the data and what are we going to do with it is still up in the air. So we decided that this can be improved upon, and we decided to form a new registry, and that's going to be our CADASIL Community Natural History Study. And we shopped around a lot, and we ended up with NORD, the National Organization of Rare Disorders. Their I Am Rare platform, which has been very successful. It's a very rigorous process of getting the registry set up, but once it is set up, I think it will be very good. And we're almost there. Like I said, we're to the stage of we're looking for a few people actually to test out our survey, and but I think it's going to be good. But you can ask, why have a natural history study? Why should we be adding to the mix? You already heard about the other observational studies that are going on in the U.S. Well, studies come and go. People lose their funding, and often the follow-up dies at that point. Patients are often lost to follow-up. Data are siloed. I know this from personal experience. We were trying to put data together initially, and we just had the door constantly closed in our face. So we decided that it would be good to start from a strong position and start our own registry that we own the data, the patients own the data, and then go from there. So cureCADASIL's registry, we're thinking, could function as a patient-owned information source that maintains long-term contact with patients and investigators and helps preserve data, break down silos, and pave the way, ultimately, to clinical trials. So why the NORD I Am Rare? Well, it's very easy to use. They're very experienced. Again, we own the data. Tools for participants to view the data. They can go online. They can look and see, well, where do I stand compared to the demographics of the whole registry. It's really very nice. It's very flexible. The questionnaire can be tailored, and we spent a lot of time putting in what we think are the right questions. The NORD offers a lot of support, mentorship. They have annual meetings of all the registries that are involved, and they have now about a 40-year track record. And we put together our own advisory committee, and you can see the representatives on the committee All of the current observational studies in the U.S. are on our committee. So we have Fanny representing, of course, our CZI and VASC brain study. We have the Consortium represented, Jamie Elliott from Madison. Elisa Penzinger was actually instrumental in putting their data collection instrument together. Elisa, who you just heard, all of them are now on our advisory committee. So I think it will put us in a good position to help break down these silos. And we've talked individually with everyone, and eventually the data that they're collecting we should also be able to get on our registry. So what has been our approach? Well, we're looking also for adults with CADASIL or who are at risk. That is, they have a family history, but they haven't yet had or developed CADASIL themselves, similar to the criteria that the Consortium study has used. We're really minimizing the demand we place on participants, so we're only asking very essential survey questions. We're not collecting samples, with the one exception being if they have had genetic testing, we get the genetic report. But otherwise, from the get-go, we're not collecting blood samples or MRIs. Instead, we're just collecting information on where we might get that data if someone in the future is interested. And so basically, it's limited to the survey questions, a genetic report, and information on availability of other data, if they had an MRI, where they had it, when they had it. And we also hope to be able to link to other data sources. So in the end, follow-up may come from the National Death Index and whatnot. So we'll be able to keep tabs. Our real goal is to keep tabs on all these patients forever, you know. And it will take a lot of effort and resources to put into it. But I think it's necessary. It's valuable. You know, with our in vitro registry, without doing almost anything, we ended up with about 500 people who signed up. But they were never followed up, and almost all of them only entered part of the data, and they only did it once. And so I think that if we go about it in a much more rigorous fashion, we'll have a lot more success. And the other piece of this is no one knows in all the observational studies who is in all of the different studies. I mean, we know there's a lot of overlap, but none of the studies have collected what other studies these individuals are in. And that's really one of the first questions we ask in our survey is what other studies are they in, so we can track them across all of these different studies. So I'll leave you with this quote. For a rare disease, every person counts. The more participants and data, the more significant its impact, and size is critically important for clinical trials and research studies. The CADASIL Community Natural History Study will show researchers we are ready to participate in research and to help find an effective treatment and cure for CADASIL. I also want to thank another board member who is really our director of this registry, and that's Vanita Ball, who couldn't be here today, but she really did the major effort in putting all of this together. So thank you very much.
Okay, our next session is clinical trials past, present, and future, and we'll be starting with Fanny, and I'll have a couple slides at the end.
I think we did, yeah. Well, if you, yeah. So I feel like Nikolaos should also stand up here. You're comfortable where you are? Okay.
He's like, I'm not leaving my chair, I warmed it up.
So when I said I didn't put the slides together, I really meant it. So this session, Nikolaos did all the hard work of putting the slides together, and I want to thank all of our partners worldwide. So we've created a clinical trial working group, and just to make it practical so that we even have the chance of scheduling some meetings, it's on the order of 10 people. We could probably have 50 people as part of that, but there are larger initiatives that I and others are participating where it's much larger groups coming together to think about vascular cognitive impairment and dementia, and CADASIL is front and center when we're thinking about clinical trials. One of those members is Micheal Wang. James Meskia is also part of this clinical trial working group. And what we're doing in this work group is to, one, go back to all the trials and see what has been done, learn from them, and also think, what do we know biologically that makes sense, and what can we test that wouldn't do harm, but allow us to test at least our strategy, design, and biomarker approach, so to speak. So, oh, it's starting with yours. That's the end. It's number 12. Okay. Okay, no worries. So it's a good thing that I started talking. So when Nikolaos, me, and the group went through the clinical trials, I was actually surprised that there is some signal actually in a very, very old trial, namely donepezil, and so we'll review that together. And one of the running threads through all these trials has been that most of them have used imaging as an outcome. And going back to something that Micheal had, perfect, yep. Something that Micheal had on his slide is NIH and pharma. Did you have FDA there? I think maybe we need to add FDA, because one of the reasons why one of the partners that we need to bring in and really work with closely is FDA. Every time I think about clinical trials for CADASIL, which I think about all the time, is what kind of clinical outcome are we going to have? You guys know as well as us, if not better, that disease is presenting in very different ways in individuals. And when you have such heterogeneity, then you wonder what your clinical outcomes should actually be. And it would be so much better if we could have biomarker outcomes. We don't know if that's going to be feasible, and I think these conversations really need to happen. So there are 3 large buckets that treatment trials fall under. 1 is symptomatic, 2 is disease modifying, and ultimately curative. Now, the line between symptomatic and disease modifying is not 100% clear. I think there are a lot of disease modifying treatments that may be symptomatic or vice versa, because the truth about clinical trials and in-human treatments in general is that we don't exactly know what's happening. You know, every step along the way, and I have a slide down the line that shows we understand cells to a certain extent. I mean, we understand in vitro systems well. Then we understand cells to a certain extent, organisms to a certain extent. Once it gets into humans, it's all sort of guessing and extrapolation. So there are things that may be disease modifying that we don't know are actually disease modifying. And I'm going to put out there some blood pressure treatments that we think, you know, are treating blood pressure, and that's how they're actually impacting disease, but they may also be having effects on the biology other than just decreasing, you know, your pressure. So these are the 3 buckets. And now Nikolaos went through this and gathered all the information, and you can see that there have been quite a few. And the outcomes or the purpose of the trial, I think was pretty much indicated by who the clinical trialists were. Were they stroke docs? Were they thinking about cognition and behavior more? But the same individuals were probably enrolled in the trials, and some outcomes were measured and not others. I think this is another thing that we need to think about, and this is why working together as a national and international community is really important, because I don't want to make mistakes that I could have avoided if I spoke to someone else who would see that blind spot. So we're really bringing all of our brains together to think about what would be meaningful outcomes that we should have that hit all the different angles that CADASIL would have and not be too burdensome. This is the trial that, Jane, you bring up a bunch, I think. And when Nikolaos went back and dug out the paper and the data, this is donepezil. It's a drug for Alzheimer's disease. And I would say thanks to this trial, it now can be prescribed for vascular cognitive impairment and dementia. So this means non-proven amyloid tau cause of cognitive decline. And as you can see, actually, it had some effect on executive function. And so, you know, should everyone be on donepezil? I would say we don't have evidence for that, probably not. But if someone is experiencing symptoms of cognitive changes, should we try donepezil or the acetylcholinesterase inhibitors? I do. And I think that's when, and this sort of opens a door, because physicians are really cautious, especially neurologists. So I think any kind of study or trial allows us to do more for the patients than otherwise. And these are what falls under disease-modifying treatments. I think it still remains to be proven whether they're actually disease-modifying treatments, but you can see that a lot of them are going after blood vessel health, but also neuroprotection. So as Micheal showed that there are different, you know, if Notch3 mutation, from the mutation to the pathology, there are different stages of the molecular abnormality that you can go for. I think the same way about the macro scale of things. So you can go for the immune system circulating, like systemic, before there's even maybe any blood vessel abnormality. You can go for the blood vessel abnormality. You can go for the different layers of blood vessel abnormality. And ultimately, you can also go for the downstream protection. One of the things that we have realized, and we've kind of known by just virtue of CADASIL being heterogeneous, we know that there's resilience, that your brain scan can look really scary. And often when you have CADASIL, the white matter changes can look really scary. But a lot of people don't have atrophy. So their neurons and the rest of the cells in the brain are incredibly resilient. So going for neuroprotection is a great idea to a certain extent, because you could potentially ultimately combine things. You could have multiple different treatments. We're not the only ones who think like that. For CADASIL, the Alzheimer's field, frontotemporal dementia, all the brain disorders are very interested in combination therapy, because to prevent clinical decline, you probably need to hit human diseases from multiple different angles. So the more treatment trials, the more diverse targets for therapeutics, really the better, because ultimately we probably need to hit multiple things. So and I think we can make these slides available. Are they automatically available?
Yeah, this whole thing will be recorded.
Fantastic. And so if Nikolaos has made no mistakes in his slides, he's all good, but then you can. So to summarize, you know, symptomatic, disease modifying, and curative, and I have one slide that I want here. So this is what really we're focused on. It seems simple. I will run. Oh, sorry. I thought it was a question. Okay. So this is really the early stage. I'm showing you in a cartoonish way sort of proteins and things that bind to them. But the blood that you provide will go to developing biomarker strategies. And we're already starting to realize that there are some proteins, and this could be actually anything, any molecule that you can measure in blood, but there are a ton of things that change in CADASIL, and they change early. This is the coolest part of it. We are getting signatures in blood that can help us perhaps track disease before even symptoms start. This is not unique to CADASIL. We know that that's true for other genetic causes of disease, and we're very excited to go from what we call signatures of disease to actual biomarkers. That's where the work gets a little bit boring, because you have to develop assays, and show that they're really robust, but it's really important. And we'll do that in partnership with people who basically develop assays that end up becoming commercialized and end up going into clinic. So this is really important, and I know through collaborations with other groups around the globe that many groups are working on this. So in the years to come, I'm excited about the biomarker strategies that we're going to have at our disposal. Until novel markers are developed, we already have pretty good ones. Nikolaos showed you neurofilament light, which is not specific to any given disease, but in multiple different diseases, the levels go up in blood, and especially in the setting of small vessel disease, which CADASIL is one. And so here, Micheal alluded to RNA, or to go after just even expression of the protein before the protein gets expressed. So we and others are working on that. What happens if you knock down the intermediate molecule and you don't even allow for the protein to be expressed? The question that we have here, and the reason why you wouldn't just jump at that, is that maybe Notch 3 is doing things that's important. And what we're not able to do super easily is to go after the problematic, the angry red one, and leave the good copy intact. Because the moment we can do that really nicely, I think it's a no-brainer. I may be wrong. But what is sort of giving us a little bit of pause is that we right now can just decrease the levels, not super specifically. And what we have developed are from human cells that you guys have donated to the research. We've built models in a dish that allow us to test some of these on cells. So far, so good. But I think we need to continue to test them on more complicated models and understand what they're doing that's helpful and what they're doing that's not helpful. Then we take it into mice, and we will likely collaborate with people like Andrew Tell, who has very, very, very good mouse models. But right now, what we're really focused on is to making sure we don't kill mice. We just want it not to be toxic. We want it to distribute to where it's supposed to go. And by we, I mean, I'm saying us really, but also others. This pathway that I'm showing you is how drugs get developed, novel drugs. And here we're really focused on that intermediate, but it can be anything. So you have a target, then you go through these steps. Now that these human cell models are available, many people are testing it there. Then you go to the mice, and you make sure that your drug is actually reaching the organ and the cells that you want. And then you test it in what's called non-human primate. We think that biologically they're just closer to humans. You make sure you don't kill them. Then you do a phase 1 trial. I think this would have taken a really long time, maybe 10 years ago. And we've just gotten really much better at this. And that's why I am really hopeful that we're going to have cool things coming to this stage. This stage, it's just always takes the same amount of time. And it's pretty costly. So both from a resource perspective and from the fact that you don't want to do this willy-nilly, we try to bulletproof it at this stage. It's called sort of de-risking all the agents and then take them to this stage. And ultimately, we will be celebrating all together when we get to this stage. So while this whole process is ongoing, what we want to do is do repurposing trials. So, I talked about some of the blood pressure agents that could have disease-modifying effects. They're safe. I mean, billions of people probably have taken them. Can they have an impact on CADASIL? How we will know that is by testing them with whatever clinical outcomes. They're not going to matter much. But then we're going to test this. We're going to see whether in the blood of individuals with CADASIL, we're getting any kind of signal that they could be effective. So that's really the plan. And you can hold me to it, because I want us to have some sort of clinical trial in 2026. So if I don't, you can, throw tomatoes, whatever, that year when I come back. But together, you can also throw it at Micheal because he'll be part of it. But I think that's what I want, and safe enough. Give us sort of how we need to design this, how are we going to recruit it, what is it going to look like, and sort of work our way to having something really ready for game-changing novel treatments. Your slides.
Yeah.
Thanks for standing by.
Yeah, and I will say that this roadmap that Fanny presented to you, that this area here can take a long time, because I work in drug development and I work in that space, but I live in this world with safety and tolerability and professionally. And boy, when you get to that point, it goes fast. But it takes a lot of money. Yeah, you can push them faster. And there, as she said, there's a process that you go through. And so it's well-oiled machine. And by that point, you probably would have a pharma company backing it. But until then, we're here and helping the researchers get grants, the $1 Million Bike Ride that many people here might have donated to and helped fundraise. That's funding Michael's work. So we're pushing this along. And so my slides, if we can go to the next slide, thank you. There we go. My slide shows that, and I'm going to go back to my notes so I can be quick, because I know we have a panel, and then you can have lunch and be in a warmer room. But so my slides is I wanted to introduce, we've always had a scientific advisory board, but we're now at a point where we really need a really strong working scientific advisory board. So I'm excited to share that the work that cureCADASIL is doing is to build strong relationships and partnerships with our researchers that is focused on moving us closer to future clinical trials. And we believe that by uniting the patient voices with the scientific expertise, we can accelerate the development towards treatments for CADASIL. And to guide us on that mission, we have recruited a powerhouse here of respected experts, and this is our newly formed scientific advisory board, and it brings together leaders from diverse fields. These are not all people in CADASIL in order to really make that progress. So we have experts in genetics, gene-based therapies, oligonucleotide therapies, innovators using artificial intelligence and lower organism models like fruit fly to potentially help identify therapeutic targets. And importantly, we have leading CADASIL researchers who have dedicated their careers in unraveling the complexities of this disease. And that's Fanny and Angie Tell, but that doesn't mean the rest of the researchers like Micheal and Elisa and Karen. They're all important. And one of the things that came from our scientific advisory board meeting that was on June 6th was our kickoff meeting, was that the team had said, well, we also want to have advisors that are experts from outside. So we'll be pulling in expertise from outside as well. So under this banner, we have this banner of Solve, Advance, and Accelerate. Our SAB is here not only to advise cureCADASIL, but to actively partner with us to move the needle towards effective therapies and clinical trials. And part of what I'm saying in that sentence is that we do the fundraise of the $1 Million Bike Ride, and on the average we have raised $80,000 to $100,000, and so we want members of our scientific advisory board to be part of that committee that advises us as to where can that money best be used to move forward the research. And one of the things that we also did with our board here is we posed these 5 questions, and there was a lot of discussion around these questions. The meeting was 2 hours long, and then it went another 40 minutes with some members. So that was exciting, actually, to see that level of engagement. But just briefly, we want them to inform and advise us so we can have impact. And what the questions that we put together here is that how do we better understand how many people are truly affected with CADASIL? You heard Julie Rutten speak specifically about that, and you heard that throughout the presentations today. but can we get more accurate prevalence estimates that can open doors to investments from pharma or maybe grants? Because it's hard. I've heard it's hard to get grants for CADASIL. I think it might. Has it gotten easier? No. Yeah. There was concern about NIH funding. Yeah. But also another question is, as you've heard about biomarkers, and I hope you understand that you're the biomarker. Your body holds the key to identifying biomarkers. So these biomarkers will identify the right biomarkers that are essential for successful clinical trials. And then the next question is, what therapeutic strategies hold the most promise? And Micheal, you did a great job of illustrating, like, what are the different strategies that could be used to target this disease and have a disease-modifying therapy. And we brought together people, we brought together people from diverse fields in order to have expertise in those different modes of getting to a therapeutic. And how can our natural history study serve us as a source for enrolling in clinical trials? And Bert explained nicely that not only does the registry serve to have a list of people who would be probably interested in a clinical trial. As Bert said, our registry hopefully will be something that continues collecting the history of patients over the years. And finally, how can cureCADASIL build the right bridges with academic and pharma to make this all happen? And I just have one final thought here for you is that the board, one of the things one of the board members brought up is like, well, what's your engagement with your patients? And so I gave a little rundown of what we're doing and what more we want to do to hopefully help engage even more people, have this room filled, that we have to have twice the size of a room. But here's what you can do now to be a part of making progress, and that is join a natural history study if you can fit that in your world, and sign up for our new patient registry and follow the progress. You can go onto our website and subscribe to receive our newsletter. Follow us on Facebook. Follow our social media, because we all want a future with therapies, and a future moves faster when we all move forward together. So we're now going to have a Q&A session. I think we're going to have to do a little chair arrangement up here, and so give us a minute for that.
So, questions, now's your chance.
I see a question. I'm going to bring you the microphone.
So I'm curious to find out, what is the differentiation between just having the Notch3 mutation versus actually developing CADASIL? I noticed the terminology of developing CADASIL was used, and I had previously assumed that, if you have the mutation, that is in itself the diagnosis. So I'm curious where that differentiation is.
So there's you're going to have differing opinions with regards to this. I'll tell you mine, but I think this is shared at least by many. In autosomal dominant, so means having the mutation should, in theory, lead to the disease. There's the terminology preclinical. I like the terminology asymptomatic, because preclinical sort of assumes that you will develop the disease. And I think maybe that, for the most part, is true for some mutations, at least insofar as we know, like presenilin 1 mutations. But we know now, actually over the past 5 years, multiple studies coming out, that even in those highly penetrant, where you have the mutation, you'll get the disease in a predictable fashion, so give or take 10 years from the mean age at which your family members develop the disease, so very, very predictable. Even in those cases, there are individuals who escape their fate. And and what has been discovered by studying those individuals is that they have other changes in their genome that are biologically countering the effects of those mutations. And it has opened up whole fields of investigation that is awesome, because it tells us that you're not doomed to developing the disease, that the biology is not fixed, that you can do something about it, and that maybe instead of thinking about what can we do about the injury or disease, what can we boost to counteract that biology. That's one. But I think for Notch3 mutations, I think we've known even outside of these that within the same family, you have someone who has devastating strokes starting super young, and then you have other family members with exactly the same mutation who don't and who have a very different life. So I think that biology, that kind of loose association means that I think we should probably say asymptomatic, at risk, or carrier, and then what I really like in general, because it then holds true, is that you have sort of clinical staging and then you have biological staging, and that's been really helpful for Alzheimer's disease, and I think we need to develop that together. Many Europeans, including the Dutch group, and you heard from Julie, are doing a lot of work to develop that kind of framing for CADASIL, which I'm very supportive, and we contribute to that because I think it's going to be very important. And then it allows someone to say, like, this is sort of where I'm at. The other aspect of it is to build better predictive models. So we know a lot more about Alzheimer's and how it progresses, but we're still terrible at predicting who someone, where someone's going to be in 5 years. And I know that for anyone having any condition that they're diagnosed with, that's what matters most, because you want to plan your life, make choices, etc. So this is really front and center, and all of these observational studies, including the NIH one, ultimately will feed data into these predictive models so that we can do better prediction. Any other? Michael? Or you? Great question. What's the question? The difference, we're too cold to hear the questions here. The difference between having a mutation and having CADASIL. So CADASIL would be sort of the syndrome, but having the mutation puts you at risk of developing. Anything that you want to add?
How does that go? I would echo, Fanny, your personal experience, having met many, many CADASIL patients, that it's just a widely divergent experience. And I kind of like Julie Rutten's definitions of, having a Notch3 carrier state versus having CADASIL, which would be more towards, higher symptom burden.
And I wanted to add from the patient perspective that, at least for me, that's the most important thing. Like the question of what's going to happen to me, for how much of my life am I going to be mobile and cogent and able to, live my life, versus if this isn't going to affect me, then I should stop spending all my money now on traveling. No. So I don't run out when I still can need
Travel
it.
and tattoos.
More tattoos always.
Are there any other questions? Oh.
Hi, thanks. Yeah, we're kind of new to this. She just got diagnosed a few months ago, and so we really don't have a clue. No family history. She's got a family history of Huntington's disease, which we were testing for, thinking that was the path, and then that came back negative, and then they went for this round, but is there any, like, she basically skipped all the headache phases of life and just went right for the strokes, and now has cognitive issues and balance issues and that sort of thing. Is that like is there like an accelerated version, or and listening to Julie, I was looking through her charts to try and figure out where on that deal her mutation was, and I couldn't find it, or it didn't make any sense to me. But I guess, yeah, seeing June and Key living seem to be very normal lives yet. She doesn't have that. I mean, is there an accelerated version, or how does it all lay out like that? If any experience would be great.
I can comment on that a little bit from my clinical experience, and also seeing, and I'm curious to see what you all think, but we still don't know, even in the world of a stroke, what happens with these brains that, as Fanny mentioned, made them more resilient than others. We still don't know how much the environment plays a role, either growing up or currently, and other comorbidities too. We know there are conditions that can sort of like accelerate things in CADASIL, for example, certain infections, and that affect the brain specifically. Perhaps that sort of like reserve, make things go a little bit faster for some people, but those are kind of like specific cases. But I think that there are cases where things could go a little bit faster for others, and also how much resilience will have someone will have after a stroke is also something. Not all patients who had the same kind of location stroke will recover the same way. So that's been my experience, but not sure if someone else had a comment on.
Yeah, so I think the puzzling thing, Julie and Saskia's work is really helpful on a group level, sort of allowing to, in a zoomed out way, understand some trends and some associations. But on an N of 1 level, so each individual, it can't explain that given individual's trajectory. So when I started first seeing patients with CADASIL and started my lab working on CADASIL, I thought this disease took decades, and then some people had strokes, and those may have caused sort of more rapid decline, but then also then a stabilization and so on and so forth. And that's not the case. There's a lot of variability. I have had patients who declined more rapidly. I have had patients who have been steady, and we don't fully understand the reasons. There are also patients, they're literally the only one in the family who is symptomatic, period. So what I do on an individual level, I try to understand everything that I can treat for that given person, and that's really head to toe. It's all the vascular risk factors, blood pressure, lipids, glycemic control. So even outside of diabetes per se, how do the sugars, how are sugars handled? Sleep, a really deep phenotyping of sleep. June was one of them where that could be addressed. Stimulation, social, so we know that an active brain is a brain that does better. So engagement of your partner, your wife, and it doesn't need to be like Sudoku or cognitive, task. It's just that activity of the brain. So it could be social, more engaging things. And that's because there are things that can be done that can impact. And we know that from more rapidly progressive forms of neurodegenerative disease, such as frontotemporal dementia of the genetic subtype, people who move around more and are more active just have a better course. So just optimize absolutely everything. And outside of that, then, maintaining quality of life, however best. But I hope that in the next decade we'll have a better understanding of it, but your experience is one that is shared by others, and we are failing at being able to predict that just based on the mutation.
there any questions online?
So this is for Dr. Wang. This might be very specific to a slide, so forgive me, I don't have all the context. But can these chemicals, if they can be administered as a drug, have an impact on patients with either early or later stage disease?
So in theory, a drug that's developed that prevents Notch from converting into a bad conformation could affect multiple stages of disease. I think it all goes back to the question of, whether there is a predictable course for every patient. But I think I agree with all of the experts here. There's no typical course. But I think in theory, a drug that's developed against early stage of the process can help patients in early disease and also later in disease.
Okay, thanks. And then during your talk, you talked about the $1 Million Bike Ride. How did the $1 Million Bike Ride fund your research?
We applied for a grant in the program, and we proposed a set of experiments, and the program reviewed our grant, and we were lucky enough to be a recipient of the funding. So what we're doing is we're using the funding to perform chemical screens. We're going to purchase commercial libraries and screen those commercial libraries for chemicals that have the desired characteristics. That is, the ability to reverse or prevent a conformational change in Notch.
And this was unasked, but how do you participate in the $1 Million Bike Ride? There's two main ways. You can act. What's that? You find Bert?
You bribe him.
So there's two ways, yeah.
Give you money.
So you can go to Philadelphia and bike with other folks there, or walk. My son, who's 6, and his friend, who's 6, walked this year. You can also just sign up virtually, right? So you just create a site, and you ask your friends and family to fund your research.
There's another way. I bicycle over to our official cureCADASIL post office box at least once or twice a week. And if you send $1 million check to that box and I pick it up, it will have been $1 million bike ride.
Which will eventually then be awarded to a CADASIL researcher like Dr. Wang and fund research. There are a couple of other questions for the panel. This is for June and Key. If you're open to sharing, how do you decide when it was time to stop working? As a mid-career professional thinking about planning for retirement, this is something top of mind for me.
Go ahead. Okay. I mean, first of all, it's just a question of when you're able to. Not having income is very stressful, and having to bring in an income is very stressful. So it's, I'm sure, a very individual question. Our process reminded me a little bit of when I had small children, the question of whether I should be working to bring in money, or whether just not working and not having to pay people to take care of my children, which one made more sense. So it's so much a personal preference, but I think a big factor to measure is how, if you're able to be able to think about how much stress is it causing versus how much joy is it bringing versus how much social interaction is it providing you with. I don't work outside of the home right now, but I definitely do sometimes feel a little bit isolated. And I know that work environments for a lot of people provide a lot of human interaction, which is also so valuable. So I don't have a specific answer. I know there's so many factors that are so personal for everyone.
I would say for me, it wasn't really a choice. I was getting to a point where I had been diagnosed, and said, oh, I'm just going to keep doing everything the same. And eventually, so I don't like to say my cognitive abilities declined, but they did. I was working until I fell asleep every single night to keep up, and I wasn't really keeping up. I consulted with a disability attorney and got some advice, did the testing that was needed to go out on disability, which was very different than my core values. I supported children by myself. I was a single mother for years, and it was sort of the very fiber of who I was, to work, bring in an income, and support a family. But it was getting to the point where it just really wasn't a choice anymore. I couldn't continue. I was error-prone in my work, which was horrendous for me. Other people didn't notice so much, but I couldn't keep working until I fell asleep every single night. And my medical team suggested I go out on disability. I did have an insurance policy, a disability insurance policy. Social Security did not approve me. My doctor at the time, before I was working with you, Dr. Elahi, was furious because she said Social Security doesn't understand rare disease. But luckily I had that insurance policy. It took 6 months to qualify for it, and then I got paid a fraction of my earnings, but enough to cover core bills. So yeah, it's devastating when you lose your income. But I couldn't safely work anymore. I was having massive migraines, and I had to stop because I wanted to function and live. But I will say, to your point about all the other aspects of life, I began volunteering and using my professional skills locally and cause-related situations, and so that kept me going cognitively. I believe, this may be a misperception, I believe I function at a much higher cognitive level now than I do 8 or 9 years ago when I had to stop working, because I rest, I get all the things that we need to do to nurture ourselves. Wasn't even part of my thinking when I was working so hard and barely sleeping. So choice was removed as an aspect of my decision, but I feel like despite years and strokes and migraines later, I'm much less symptomatic in some ways, and it wasn't a choice, but I feel like I function at a higher level now than I did then.
Thank you for sharing.
Tagging on to what you're saying, one thing also that I think about is I assume that in the future, whether the near future, the far future, that my husband is going to have to sort of take care of me more than he was initially planning to when we married each other. So one thing I think about is I'm going to sort of try to pay it forward with him as much as I can now, and support his career and support him as a person and be as nurturing as I can, because I know he's going to have to, do that for me at some point. So that's another thing that I focus on. And also, just echo your point about volunteering. One other thing I've noticed is that it's harder to feel bad for yourself when you're helping other people. Yes. So there are so many diseases in this world, some rare, some not so rare, but they're and any sort of expansion of compassion that you can have for other people going through other things in their life, especially related to health of themselves or their children, is very, again, it makes it a little harder to focus on how bad you feel when you're helping other people. Sounds trite, but true.
Can I ask a question to the whole panel? Thank you. I am a mother of 2 children who have been diagnosed with CADASIL. I have a youngest one who is 46, and she's very much afraid to find out. My question is does she have a chance to have CADASIL? Somebody told me, we are from Chile, and I went to, when I found out about my children, I went to Santiago and talked to a very famous and good neurology doctor over there, and she plain told me that no medicine, no cure, but no complaint because I was in the right place in this country. They're fighting to get something to, to cure people for CADASIL. My first question is, does my youngest one, Gabriela, have the chance to have CADASIL? And what about the mothers who are learning to navigate this new life? I was completely retired, living in Chile.
Living a good life.
Living a good life, 3 blocks from the Pacific Ocean, walking. My daughter, Mommy, you used to walk for 2 hours. Why don't you walk? I don't feel like walking. I also was a single mother. I was forced out of my country because of coup d'etat. And they told me, you just be quiet or you leave. And I had to take my 2.5 children and move, because I was pregnant, and moved to this country, finish college here, work my ass to raise my 3 children. And when I am, in Chile, having the rest of my life, probably 3 or 4 more years, because I am 78, I'm going to be 79 in a couple months. And I had to learn again to live. Yes. That's my question to you, to everybody. Does Gabriela, my youngest one, have a chance to have CADASIL? And how I learned to live this new life?
So I'm gonna give a comment that's not gonna be an answer to your question, but I'll start there. You have to take care of yourself very, very well. And I know that's impossible almost for a mother, because I'm a mother of 2. And I know that you would rather be sleep deprived, get their virus, get whatever they have, and they remain untouched. I empathize with you fully, and I know how hard it is, but we know through a lot of studies that being a caregiver or the loved one of someone who's affected can impact your health. And even if you do it for the love of them, you have to remain healthy. So focusing on your health is loving them and caring for them. That's incredibly important. That's one. And then your daughter stands the chance of not having CADASIL. So it's 50% chance of having CADASIL, or 50. It's basically a coin toss. And I think she's very young, and I think he alluded to this, but we're working our butt off, and we're only a fraction of people working on this disease. And I think that gives me really great hope for their future. So live with hope and care for yourself, because that would be caring for them. Exercise. I don't think we talked about exercise enough. I think exercise is probably, while we're looking for drugs, exercise is probably one of the most potent drugs that is out there.
Another, probably not a specific answer to your question, but I think that a lot of what we experience in life definitely shape the way that we make decisions, and the fact that you have that powerful history of coming from Chile, resilience from all different levels, bringing your children finish college. I assume that you are bilingual or more than that. So definitely has shaped your trajectory and your personal story to be able to stand up for your family as well. So regardless of the fear of course, you want to protect your family, I think that you have to rest assured that you have done a lot of good things for them. And I want to also kind of like say that, and it's just kind of like a plug for people that come from other countries or have different or like trajectories in life, that we still need a lot of help in our own countries in Latin America. I'm Colombian. Yes. To bring all this knowledge. So I appreciate that we are here within all the circumstances in a position of privilege in the world to even talk about new research, about new discoveries, because still we don't know a lot of the things that can happen in Latin America, in the Southern Hemisphere. So bringing the voice and thinking that not only your participation, you being here, you being telling these stories actually matter in this city or for your family, it's mattering across the world. Because once we get into opening these doors, it's gonna open the doors for a lot of people that can say, can I have a test? Can I bring my family here? So definitely all your efforts are impacting a lot of people. And definitely we're working on like trying to build up more connections in Latin America, so more people in Chile, in the Southern Hemisphere can be or have that clarity or understanding of what's going on in their brain. So I appreciate you, I appreciate your family, and I agree with Fanny. Let's keep walking. Even if you don't have the Pacific right now, you have the lake if you live here. So try to walk as much as you can.
I just want to say that Karen has spearheaded gathering researchers in the Southern Hemisphere, as she said, many countries, spearheading it relentlessly with perseverance, and it's going to happen one day. Yep. You should give her the $1 million bike ride for that.